Or
Thank
David,
you. Thank you, David. We're live. We are live now. Thank you. Welcome, everybody, to this live stream that we set up a bit earlier in the day. We have Sarah Hawkins, who's a doula here. We have Elizabeth, you have a media background. That's right, isn't it, Elizabeth? And you're a singer as well. Yeah. And Professor Richard Gill, many of you know. Is there anyone? We're getting an echo here. I wonder if is it coming through one of the other?
Is anyone here not got earphones in?
Someone left the YouTube on.
I don't have ears in.
Yeah.
Can you get some AirPods, Liz, or do you have earphones?
Yeah, it's coming through. I'll just try.
It's gone. It stopped.
Bit of. Hello. Yeah, we're getting a bit of interference. I'm not sure how to deal with that at the moment.
Has anybody got the YouTube channel on as well as the studio? Because that's what when I first come here, that's what I did. So I've made sure that this is the only window I have.
Right. Hello. It's probably me. I'm so sorry about that. It's probably me. So I think that's better, isn't it? Great. So yeah, I was just introducing everybody. I've got Professor Gill, we've got David here, who's got a nursing background, a professional nursing background, and perhaps I could just hand over to you, Sarah, to begin it off about. Is that all right? So we can just begin discussing it in an ad hoc way.
Okay. Well, let's. Can Liz, or if I pass it to Liz to kind of lead the kind of opening it up, because yes.
Yeah, of course, absolutely. Whatever you're comfortable with, yeah.
So just to preface for Sarah, the expressions that are going to be...
Oh, there is feedback. Someone's got feedback.
Yeah. Has anybody got the YouTube channel open at the same time as the chat? That might be doing.
No, I've just stopped it. So you're the only window.
Is it you, Richard?
I don't think so. I don't think so.
I think it's David, because I've just muted him and it stopped.
Okay.
I'll just ask him. David, is there any way you can adjust? I'm not sure what you adjust, because I'm not that technical, but I think it might be coming through your speakers, so we're hearing that. Because when I mute you, it goes away, but I'm not sure what to advise. I don't know if anyone else knows.
Well,
is it not me? Is it me that's feedbacking?
Well, what I've done just now, I've muted David, and we don't have any of the feedback. So
okay, he's obviously got it loud through his speakers.
Yeah.
Moreover, when David speaks, it's very, very, very loud. Is there
anything you can do? I'm not sure, or try headphones, David. But or anyone in the chat can advise us how to get going on that, because I don't
turn his volume down. That's all.
Oh, do you have to? Yeah, right. Did you hear that, David? That tried the volume setting, please.
I'll come back and figure it out.
Do you want me to start, Sarah?
Yeah, go.
Okay, so for the viewers and listeners, we're about to express personal opinions on.
I have to mute. Sorry to interrupt. I'll have to mute you, David. Sorry, no, nothing personal, but it's just the interference. So, if you want to start again, sorry, Liz.
We're about to express personal opinions and views on the Lucy Letby case regarding twin and premature births that ended up in neonatal intensive care. The following live is for entertainment purposes only, and they are merely our thoughts and our expressions of the people that sit around this table. So, Sarah, you wrote an open letter regarding the Lucy Letby case. So do you want to kick off and say why you wrote that letter?
I wrote that letter because of the way that the conversation was being had around it, and I felt that I could bring some insight to the conversation that might benefit all those involved, really. And so I reached out to a few people, one of which was the wonderful Professor Richard Gill, there, sat in front of the beautiful artwork. And as gracious as ever, he met with me and we discussed it. And you know, he's been very, very kind and helpful and supportive. So yeah, just trying
Your
to.
letter's quite involved though, isn't it? So what prompted you to write that letter? What was it that made you think I need to sit down and write about this?
The fact that I saw things that were either not being discussed or were being discussed inaccurately. I'm obviously the mother of twins. My twins were born in 2015. They were born at 32 weeks premature following poor care. They were in NICU. They nearly died. And they were in NICU at the same time as the first two babies in the Letby case were. And
really?
yeah, so I have personal insight into what it's like to be the mother of twins who were unwell and at that time. And I've also worked in maternity, and I've, you know, as you are, Liz, a patient expert in your own right with the condition that you talk about, a patient expert that has for 5 years now really dedicated my life to trying to improve things within maternity. And I just wanted to bring some voices from the twin community, I guess, and share my insight, but also things I've seen, heard, and I know in a way that is mindful and respectful. So that's me. So, and I don't know much about Mark, so I'd love to know about Mark, and Richard as well. Probably introduce himself just in case there's people that don't know who he is, although I can't imagine that there wouldn't be.
Yeah, Mark, introduce yourself. Let's go.
Oh, I think we've got there's something going on with the sound, David. I'm sorry to mute you again. It's there's an issue with the feedback there. Sorry about that. I feel rude doing that, but there's no choice really. But anyway, yes, I'm Mark. I've got no particular professional background, nothing medical or scientific or anything like that. But I became interested in it back in well, during the trial itself. I was following the trial through various means, and I began to feel just an intuitive feeling that something was very wrong. And I began making videos about it pretty much as soon as the convictions were in. And I haven't stopped since then. And I've met a number of people, quite a lot of people over the intervening, getting on for the best part of 2 years now, obviously, including Richard as well.
Yeah.
And
Gill sent me some statistics, and it was just quite eye-opening reading, to be honest. So I can see why you sort of got interested in it, because something did go horrifically wrong.
yeah, I'm trying to. I'm sorry, David. Yeah, I'm tying up with the sound issues there. I don't know if. So, were you going to say something, Richard, about yourself there as well? Sorry, David.
Okay, I'm a retired professor of mathematical statistics, and I got involved in serial killer nurses back in the early 2000s, because we had one in the Netherlands, and her name was also Lucy, but her real name was Lucia. And she was initially convicted using statistics, something which in the Lucy Letby case, both the prosecution and defense actually declined to do. I mean, they showed statistics really, because they show data and a summary of data, but they don't do any probability calculations or whatever. Lucia de Berg was convicted on the grounds of a probability calculation with the amazing probability 1 in 342 million, that just by chance a random nurse could sort of at random be present at so many events. And that was very controversial. And at the appeal, prosecution didn't use statistics anymore, because they understood that people found that very unsettling, that you'd convicted somebody on the basis only of some statistics. And so we kind of forgot about it. And then in 2005, some whistleblowers started getting active, and they showed that the idea of this impossible coincidence, that this same nurse was there every time when bad things happened. Now that permeated the medical evidence. The medical experts were influenced strongly.
Wow. Okay.
They even said so, like medical experts said, normally I would have thought this event was normal. But since Lucia was there, I think it's not normal, right? And according to the Dutch judges, this was irrefutable scientific medical proof that Lucia was guilty. Now, when that kind of came out, which was in 2005, I was really furious. And so I got very deeply involved in the case, and I was one of the people fighting with some real whistleblowers who were a medical doctor and a philosopher of science. I was just a kind of spokesman and a campaigner, and I was kind of the bad cop because I went on TV and said things which you shouldn't say in public, you know. But this gave me expertise in serial killer nurses, and I got involved in an Italian case and a British case of Ben Geen. And so, and I saw Lucy Letby coming up from the first, you know, a news item in The Guardian back in 2017, probably. You know, police investigating suspicious spike in deaths, a nurse being investigated. And I thought, bloody hell, here we go again. And I followed it.
Has there ever been a case like this, Gill, in the UK before with Letby?
Yes.
There has.
Yes, there are 4 other very similar cases.
Okay.
There's Ben Geen, there's Colin Norris, there's Victorino Chua. And the most famous one, about which opinions may be divided as to whether the nurse in question is innocent or guilty, is Bev Allitt. I have doubts about Bev Allitt's conviction. There is insulin evidence that a child was harmed by insulin poisoning, you know, deliberately harmed. There is statistical evidence, which I never looked at. And there's psychological evidence. She had some psychiatric issues, psychological issues. As a teenager, she did self-harming.
So do you think that the statistics in the Letby case were used correctly?
Well, in one sense, there were no statistics used at all because nobody did any probability calculations. Both the defense and the prosecution actually got advice from experts in the field and decided not to use it. They decided not to use statistical advice. In fact, the prosecution, a high-up guy in the CPS, well, I'll tell you why. The high-up guy in the CPS said, we're not using any statistics because it only confuses people. And why the defense didn't use statistics, I don't know, because they did get advice from a very capable person. But they were scared of it because people don't understand it, and it's technical and nobody understands it, and judges don't understand it, and lawyers don't understand it. Yes, but I would say there is statistics in the case because for instance, the famous spreadsheet showing that Lucy is there every time that bad things happened is a summary of statistical data, right? There is data of when babies come in and out of the ward. There is data on when nurses have shifts, and these 2 data sets have been combined. And on top of that, somebody has decided to call certain events suspicious incidents. And the defense lawyers in Lucy Letby's trial, and that's the important thing. Why are these events being called suspicious? Because that spreadsheet would be damning statistical evidence against Lucy Letby, had that classification of events been done in the proper way that any medical researcher knows how you ought to do in order to be able to do good statistics with the data you get.
Yes.
This is really bad. The defense realized this, and they asked the judge to that the prosecution would tell them what was the protocol or procedure or process by which events were selected and classified. And the judge refused to let them put that question to the defense. And it's the first question anybody should have asked.
Mm.
And it was never asked.
It was never asked.
So the judge stopped it from being asked. The judge was biased as hell. But of course, he's just a lawyer, and he was convinced by what he'd seen.
May I just say something?
Yeah.
We've also got the aspect of the CPS deciding to instruct the police, Cheshire Police, not to go down the route of employing Professor Hutton, isn't it?
Right.
And dissuading them from that in terms of proper statistical analysis.
Yes. Yeah, they were scared of what would come out. I mean, and what
Has
did
Liz
come
gone?
out? Yeah,
Liz has disappeared.
She's disappeared.
Are you okay? I think Liz chose to take herself off. I can would you like to come back on, or?
Yeah.
Are you okay, Liz?
There you go.
Yeah, I'm here.
Oh, right. You, for some reason you disappeared. So I don't know how that happened. So, yeah, I didn't press anything, but
before we go any further, I just want to say Julie is here. I just have to give like a huge shout out to Julie, because bless her heart, right? She has been so consistent, like in helping and supporting, in listening to me and trying to like approach people. There's a lot of like weirdness within the whole kind of Letby stuff, and she doesn't really get in the weeds of that. I don't get in the weeds of that, but she's I just have to make sure that people know just how committed that she is to this, and has been very, very, very supportive, and just a really great presence. I'm really pleased that you're here. I thought you were sick.
I think you're muted, Julie. I'm sorry. You've muted yourself, or you're in a muted situation, as it were. I can't unmute you.
The dog was huffing and puffing, so
there you go.
Myself, so you can hear him.
Yeah.
And in the background. Yeah, I'm on the sofa, so I'll try. But thank you, Sarah. That was lovely. Thank you. Yeah, I'm glad to be here, and thank you, Mark and Liz.
Cheers. Well, thank you all. Yeah, thank you, Julie. Lovely to see you. Yeah.
Mark, what do you think they should do next about this situation? What do you think should come out of this?
That's a massive question, but there's a huge number of ramifications that will affect all kinds of institutions. I mean, you could run through the list. It's going to be the CPS, the police, the judiciary, the whole notion of how the police investigation, the NHS as a whole. But obviously, I think the point of this stream tonight is probably to bring on some of the research and the thoughts and analysis that Sarah's been doing over obviously a number of years now, isn't it? And that's what we're going to look into that.
And the aspect of the twins, the multiples.
Exactly.
Yeah.
Which is so big. And where do they all come from?
Where do we start?
I love that you're saying that. I love that you're saying that, Richard, because I think that's what I was like I've been trying to make the point of. So if I just go back a little bit to how my kind of relationship with the whole Lucy Letby situation. So I didn't know about. I don't really follow the news. I work, I have kids, and then I doom scroll occasionally on TikTok, fall asleep to real crime and cults and all that kind of thing. But my favorite thing to do on any kind of app is to find out what direction Britney Spears is spinning in today and what the Biebers are doing. And I love both of them. I love Hailey Bieber, Justin Bieber, and what's the other Bieber? His ex.
Oh, I don't
know. Selena Bieber. I love her too. But anyway, I'm a very, very, I'm very passionate about what I'm passionate about, but I don't really keep up with the news. I don't watch TV. But when the news broke, I had you know, admittedly a very, very emotional reaction to it, because obviously it triggered me. And in the work that I do, which is in campaigning for better care of twins and multiples, I found that I saw it just for the headlines, and I thought she was targeting twins. Like that was my immediate thought. And I, you know, I posted about it like everybody else, and I, you know, felt really bad. Now, if I could have a conversation with her or anyone around her, it would be to say, you know, I'm sorry that that was my initial reaction. I'm not going to say here, like, whether or not I think that she's, you know, guilty or innocent. I think it's more than likely that she isn't as guilty, or isn't guilty, or isn't as guilty, you know. There's many, many variables. I don't know. And thank God I'm not the person to make that decision. But I did attend, someone sent me a link to a live event where there were people that were talking about it from a scientific point of view, and well, some of the science kind of sort of went over my head, and also didn't account for the whole twinning aspect of it. And then within this, there's an awful, so I keep getting phone calls, there's an awful lot of conversation around the babies, including the twins, that doesn't relate to twins because it's completely different. And so, but it made me sit back and go, okay, reserve judgment, which I did. And hello, Mervyn. So then I did, and I didn't look at it again. And then going back over some research that I'd been doing and the work that I'd been doing, I realized that there might be something that I might be able to bring to the conversation that would be helpful. And then in trying to approach people, I spent 24 hours in a group, and at 24 hours only. And that's when someone said, oh, reach out to Julie who. Julie who, I love that. And she's great. And we started to try and get conversations, and then I began to feel very, very frustrated, because then I started to see some of the things that were being discussed around the Lucy Letby case, and I started to see the way that people were being treated, and I was starting to see the way that some people were being excluded from the conversation, and some people that were being, you know, overly included, that I don't think quite have the right to be in that space, to have that voice. And I also have found it very, very upsetting to see an awful lot of the automatic assumptions that have been drawn about any of the babies, because I support a lot of families whose babies have passed away, or who their babies have come to harm. And these are people's children, you know, and every single person within this is a human being who has, you know, has passions, has drives, has a family, has children, has parents. You know, they matter, everybody. And I, you know, have had a real keen interest in the consequences of NICU itself. And I've spoken about it prior to me having any of these epiphanies, whereby nobody gets out of NICU unscathed, you know. And so I just feel that, from the jump, if I say anything, that if any parents are watching, you know, I see you, you know, I you're a twin parent, and we are unique, and we are, if I can do anything that I can to try and make sure that your babies are respected, I will do that. But the same goes for every single person that's been involved. So just from that point of view, if I say anything tonight that is, you know, Liz has known me since I was 19, when I sung less well than I do now. But, you know, like, if I say anything that is, you know, a bit stupid or a bit dim or a bit insensitive, I don't mean it. I genuinely do only want the best. So, yeah, I just feel that for me, I want to smash through some of the assumptions about twins and multiples in terms of, perinatology. I want to highlight some of the distinct differences in twins and multiples when it comes to perinatology, and also, kind of give some kind of, shine a light on the very large number of twins and multiples, and perhaps explore some of the questions that I would like to see answered that I think do need to be answered.
Okay.
Is it all right to ask you, Sarah, if you wouldn't mind, to briefly describe, or as in detail as you wish to, what the role of a doula is, which is what your profession has been for the last 5 years, isn't it, or so, I believe it's been.
Well, it isn't now, and I don't know whether it will be going forward, because I kind of, it almost makes what I have to say, I think, within this, it's reductive, because as a birth doula, I support families to get their wants and needs met within maternity care, and for their choices to be respected. That's my job as a doula. But in advocating as a doula, because I'm an advocate across various sectors. My specialism is in twins, and that role is not very, it kind of is very different from a general doula, because I need to try and help families access the best clinicians, the best midwives, the best, where is the best hospital, statistically speaking, for them to give birth, and who is able to give the best neonatal care, and then there are the conditions that come along with it. And so because of my own children, they had an undiagnosed condition, because, in my opinion, poor care, and we've lived with it ever since. And so for me, I've done everything I can to campaign and understand everything about the complexities and the very unique diseases that are specific to twins and multiples. And while within this data,
do you think that the NHS can are giving the best care that they possibly could for twins and neonatals at the moment?
I don't think that, no. I can say for sure. I don't think that, and I don't think they were doing it then either. But that's not the people at the bedside, It might be, we don't know, but that's, there's a lot of questions I think that do need to be explored. But what I do want to smash through first is this idea of twins and multiples by just their, twinhood, or being multiples, are automatically more vulnerable. They are if they have some kind of comorbidity, or if there is an issue. But in some ways, they actually do better if they're premature, and that's because of there's very distinct physiological differences in a twin and multiple pregnancy, as opposed to so there is, for example, growth patterns are completely different in twins and multiples. We see the same in IVF pregnancies. And so, this is just my opinion. I'm not clinical. Apparently that accounts for a lot. There was a lot of clinicians that walked her into this oncoming traffic, but
you still have an opinion, and you are still entitled to it. So
yeah, what did you say to me the other day? I'm not a vet, but I know what a dog looks like.
I'm not a vet, but I know what a dog looks like, baby.
Yeah. So for me, I've lost my train of thought. Where was I?
It's better off if they're preemie.
Well, no, it's not better off. So basically, what happens is so within twins and multiples, the same. I think we see the same in IVF. So, and I put it down to being something of an evolutionary hack. So the body knows that the pregnancy has more than one baby, so therefore it makes these particular changes within the physiology of the pregnancy, and the the pregnancy, everything that is within the chorion, from the chorion within, is all fetal tissue. Uterus is the mother, and everything else is the fetal tissue. That something happens in that beautiful exchange that kind of tells the mother, these are twins. So they might be born early, or is this a twin, or is it suddenly just a very big baby?
Yeah.
And so then the cellular maturation changes that happen within twin and multiple pregnancy, the same with IVF, and potentially because of IVF medications, means that the cells change in a different way. And one of the ways that we see this is that premature twins, not all the time, and not, caveat everything, they can do a lot better, or they are known to do a lot better in terms of breathing if they are premature, because those maturation changes actually are what happen. They happen about 3 weeks before that of a singleton, and they cause the process that begins the process of labor, which happens way before a woman knows that she's in labor. You're in labor way before you know you are, as you know. The women here can attest, and we're often the women are the last to know. You know what I mean? So it's so but this happens before, and it's all a process of these cells change, and this triggers a change in this cell, and this cell, and this hormone, and this hormone, and this hormone, and or the cellular maturation changes cause for the fetal tissue to produce hormones that then produce prostaglandins, and blah 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 blah. So that's a lot of Twinglish.
How many twins were in the Letby case?
Who's the expert? I don't know who Mervyn is. Is he an IT specialist?
I'm just going to introduce Mervyn to the chat. Mervyn, you've unmuted yourself now. And so Mervyn is also a YouTuber who's done quite a number of fantastic videos about this for about the best part of a year, isn't it, Mervyn?
Yeah, I think it was either 31 or 33% of the deaths were twins.
Yeah,
multiple. I'll say twins, but actually triplets. I think.
Yeah,
but does that include
counting multiple pregnancies?
Mervyn, does that include the? Sorry to interrupt you, but does that include the stillbirths? Because that's the point that I've tried to make all along. Is that
no, not including the stillbirths.
From the information and the information you gave me the other night, Sarah, it looks as though out of the 17 babies that make up the babies on the so-called like an indictment list, 10 of those babies will be multiple babies, albeit that two of them, babies I and J, their respective twins will have passed away, but the in the court case they wouldn't have been made aware of that. The jury wouldn't have been made aware of that aspect of it. But it's like
they should have.
Why?
Yeah, they should have. Been, yeah. So we're looking at the figure of like 10 out of 17 in terms of all of babies A to Q. That's where we are at. Yeah.
So Mervyn, just to explain what I mean by that is, so within the twin pregnancies, a lot of the issues that will occur that might trigger preterm labour or an issue might cause the co-twin to die, but from a perinatal perspective, a twin can never be a singleton. So you must always consider the co-twin as. So for me, if a twin has died in utero or a multiple has died in utero within a situation like this, even though and I think this is a misunderstanding in the UK, people think that termination is entirely legal. It isn't. It has to be signed off by two clinicians. And at any stage in pregnancy, towards the end of pregnancy, it gets worse. There's also laws in the UK that protect a fetus once it's at the point of viability. So that's why if a woman is a victim of domestic abuse and she loses a baby, or she's attacked in the street, she loses a baby, it has its own its own crime. I think it's called a future life or something. So if something happened within those pregnancies that was not picked up or was not responded to, that potentially caused these babies to become very poorly when they were born or whatever, obviously I don't have their history. I think that it's only right that we consider them as being part of all of look at these as pregnancies and how many of babies were in those pregnancies, and then that would be the number to go with.
Yes, yeah. I think all of them should be accounted for, and they're not. So, for example, you know, I would watch the ITV news, and they don't mention that. You were the first person that actually told me that some of them were twins and multiple births, babies. Whereas the general Joe public watching, they don't know that. They just see it as a single baby. And I think that's really, they should know that. Members of the public should know what actually happened. It's almost as if wool is being covered over people's eyes. I think they should
so there's
know.
13 multiples altogether. Is that right, Richard? So Mervyn, what's that in percentage?
Yeah, let me show this my spreadsheet.
Yeah.
Go for it.
Okay. Right, may I talk about this?
Yeah.
So
Yeah, sorry, the figure that I just gave was the hospital's internal review of deaths, and not the indictment. So what Richard will be showing is probably more relevant to the stat that I just gave.
Everything is relevant, and we need to see everything. So this is the indictment is A through Q, and who's a very nice guy who made this for me. I asked somebody the other day for a spreadsheet like this, and they made it for me, and I'm blanking on his name right now. But anyway, A and B are twins, E and F are twins. I is the surviving sibling of twins. J is the surviving sibling of twins. L and M are twins. O, P, and R are a triplet. R doesn't enter into the case, but it's the sibling of O and P who went home. Well, at least was transferred out of COCH and survived. So R is a surviving baby. And this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 out of 18, which is nearly 12 out of 18. I call that 2/3. 2/3 of the babies are basically multiples. The babies in the indictment. And of course, we're not counting the sibling of I and the sibling of J who died in utero for medical reasons, I presume. But I and J remain babies who were twins and who had were born of a mother who had a twin pregnancy.
And I've never heard that mentioned on mainstream media.
No, nobody ever says that. That explains the colours. If there's anything else I want to say here, we have the picture. What does
I think it's important as well
is girls and boys. That's obvious. I've added stars here. Now, this is what I definitely wanted to tell you while the picture is here. Looking just at the gestation, so 31 plus 2 means the baby was born at 31 weeks gestation and survived another 2 days. Right, or spent 2 more days on the ward. This is 2 out of 7. That's the terminology used by Shu Li and his mates. But anyway, the main thing is I would say is the gestation, and I looked up.
You've got where it says 31 plus 2. It's not plus 2. So it's 31 weeks plus 2 days.
That's right. Yes.
Yes. You're mixing days and weeks there, really.
Yeah. Okay. It's 31 weeks plus 2 out of 7, 2/7 of a week in the notation of Shu Li, and I left out that's why I said weeks plus days. It's weeks gestation plus days after that alive. And you notice that there's a huge number of cesarean sections, enormous number, and one baby was born while the mother was sitting on the toilet at COCH, I think. And so there are very few natural births here. Well, natural, non-cesarean births. And of course, there's many more important. Now, I put stars here, and I looked up what is the criterion for level 1, level 2, and level 3 NICU care. And one of the criteria is the gestation. So 29 weeks. 29 weeks gestation is more than 2 months premature, but it's not. Sorry, it's more than 3. It's not 4 months premature, but it's about 3 months premature. So 1 star is for 2 months premature up to 0, and 3 stars. 1 star is for up to 2 months, I think, and 2 stars is up to 3 months, and 3 stars is up to 4 months, and 4 months is basically the limit, right?
So sorry, Richard.
What you can see, what I want to say is, oh my God, those babies were so premature, and that's not the only thing that was wrong with them. Sorry,
the youngest
they were
was
so premature, and already on the grounds of these stars here, more than half of them shouldn't have been cared for at Countess of Chester, because the Countess of Chester on paper was a level 2, but as far as the RCPCH is concerned, it was staffed and everything, equipped and everything as a level 1 unit, and it should not have been having any of these 2-star or 3-star babies, and it did, right. And of course they died.
Yeah. So you're saying that they were moved to a hospital that wasn't adequately equipped to.
Now that's the next thing to say, which is what I've been learning from our resident doula here, is that many of these mothers had been booked in to hospitals in Liverpool with level 3 neonatal care NICUs. Such as, especially, the Liverpool Women's Hospital, which, by the way, is an absolute UK centre, if not a world centre, for research into twins, by the way. So many of those mothers were expecting to give birth at a hospital with level 3 care.
Yeah.
And we see many of them needed it, if not level 2. And the question which nobody has asked yet, except maybe Sarah, is why the hell were those mothers giving birth at Chester, which essentially was a level 1 unit? And the specialists, the consultants who let that happen, I believe they must have known what they were doing.
Yeah.
They were
why would anybody do that? That's
they were giving those babies a death warrant, issuing a death warrant on the babies of those mothers, and I wrote out. I can think of 7 reasons. I mean, one reason could be there's just not enough capacity, and
wasn't there? Sorry to interject, but wasn't there? In the hospitals that they were currently in, there was space for them to be treated, but they were moved anyway.
Well, I don't know. This can be said, but I don't know. I haven't checked. I don't know. And I don't know where all these babies, all these mothers were cared for before they came to give birth. So I don't know, but this is something which should be researched.
Can we just go through? Can we just go through them, the twins, and then talk a little bit more about the type of pregnancy that it was, because that's also really important, whether or not they had their own placenta or they had separate placentas.
Yes. Before you do that, which needs to be done, I want to say that the stars I put here are determined by me only from the gestation. And of course, to determine whether a future baby is going to need level 1, 2, or 3 care, you need to know a whole lot more. Like, was it a monochorionic or a bichorionic? All those things. You need to know what the birth weight is going to be expected to be. You know that in utero. There are many more things you know, which say that the baby is going to need level 3 care. And I'm sure that applies to many of the 1 and 2 stars I have put here, because these stars were determined by me, who's just a statistician, on the basis of this number, the gestation, which is not enough.
Because I want to come back to your questions about, you know, the possible whys, because I loved that you made those lists, because I think that we can go through those lists, because all of those as concepts are hugely important. But just going through them,
I had a list of 7. Yes, I could even put them up.
7. Yeah, put them up after this, but let's just go through these first of all. So A and B were dichorionic twins, boy girl. Okay, and the mother was not booked at the County Chester, that we know. Then we have E and F. Now E and F were admitted
hold it a moment.
to.
Hold it a moment. Dichorionic is bad, right? It means sharing.
No. Dichorionic means they had their own. They had their own placenta. Sorry.
Okay.
Yes.
It's good.
But no, it's good if you haven't got a comorbidity, you know, which was the phospholipid syndrome. But so they so they were boy girl twins, and then E and F were admitted to Liverpool Women's at 27 weeks, and they were being monitored for TTTS, which is a form of what's called fetal transfusion syndrome. It's a very fast and progressive disease that, if it's not treated in time, is very, very dangerous. It is unique to, sorry, we've got a train going past. It's unique to twins that share a placenta. And so they were admitted to Liverpool Women's at 27 weeks. And then at 29.5, they were told that they had to give birth today, but they had to give birth at the Countess of Chester. So they were transferred to the Countess of Chester. So they were within a tertiary level hospital that could support
Liverpool.
Yeah. But Liverpool's also part of a network of other hospitals that have got really good neonatal intensive care units, but they sent outside of there. So I don't know an awful lot about. J was a monochorionic twin, so that's a twin that shared a placenta, and that baby was under the care of Liverpool Women's, and was transferred to a hospital outside of the network as well for laser treatment. We have a conservative guess about when that happened, but potentially it was too late. Just putting it out there, that's not uncommon, but I'm surprised that happened at Liverpool Women's. If it was a rural hospital, it wouldn't be. But I am in this situation. And then the mother went into labour and gave birth. I don't know, between the surgery and the birth, what caused the co-twin to pass away, or the preterm birth. And then you've got L and M. Now, this mother has struggled with some, I think L and M's father gave the testimony at the Thirlwell inquiry. There's not an awful lot known about those twins. And then O and P were triplets. Now, these were triplets that also shared a placenta. So we have E, F, J, and the triplets all shared placentas.
Wow.
Okay. Now, I sent you, didn't I, Richard, the number of twins that were born at Liverpool at the County of Chester. It was way more than what was expected or should have happened. A little more, a bit more. I think it's like a general hospital usually has like 2,500, and so if you think about twins and multiple pregnancy, 1 in every 33 pregnancies is a twin pregnancy. 1 in 333 is a twin pregnancy where they share a placenta. And so when it comes to the triplets was a 1 in 100,000 pregnancy. And they were booked at the County of Chester. We know that they were booked at the County of Chester. So some of them were booked, and then they were sent to Liverpool Women for an anomaly scan, I believe. That still happens now. And then they went back that they wanted to go back. And this is the whole point about wishes and choice that I wanted to explore with you. That what we see here is a far greater than average amount of multiples that shared a placenta that not only were born at the Countess of Chester, but that were born ill at the Countess of Chester. And the conditions that potentially they had happen in 1 in 6 pregnancies or in 20% of pregnancies. However, if it's treated,
are you talking about twin pregnancies?
Twin pregnancies, yeah. So apart from A and B, if they had, for example, they shared a placenta and they had some form of fetal transfusion syndrome, then they would be offered, they should be offered treatment. And the treatment that they can give almost switches the stats on their head. Not treating them has a high number of not only fatalities but also morbidities.
Just to confirm, Sarah, the 3 triplets, they shared a placenta, correct?
Yes. Yeah.
There you go. Somebody just asked a question.
Yeah. And also I read a Guardian article, and I pick up on this because this, you know, this is my bread and butter. I've not made no money from twins. Gosh, I've got 2 in there that keep asking me for ice cream, you know. So, you know, I've totally lost my mind. What was I saying? Where was I going? Oh yeah, no, not a Telegraph, in the Guardian, and it was the parents are talking about what the babies look like, and based upon what the babies look like, it gave me an awful lot of information, right? And the thing that I'm seeing here is that we have a greater than average number of babies who are twins, that are premature twins, born at a level 1, 2, you know, at a push NICU, who are very unwell. And even at a level 3 NICU, if they're twins, you need to have a neonatologist or, you know, or a pediatrician that has experience in understanding these unique diseases. Because if you treat one like the other, you're going to cause a catastrophe.
So the big question is, why were they moved?
I've got a question.
That's a big question.
Yeah,
it's such a big question, isn't it? And it's unanswered.
Yeah, my God, which consultant was treating all these people? If we had the consultant on each mother, and who did the surgery, and we might see a pattern emerge there as well.
If we see what? Say that again. You broke up there. Sorry.
Sorry. If we flag up which consultant were these being cared for by, and who performed the surgery.
Oh, right.
To pick up there might be a pattern.
Yeah, to see if there's a pattern in the
and then cross-reference that with if any other studies were going on that we don't know about.
I suppose that feeds into Gill's 7 questions.
Yeah, may I show them?
So sorry, Rick, can I just say, Sarah, you said there's a greater number than average of twins. But when you say there's a greater number than average, are you talking about from neighbouring hospitals, or are you saying from previous years at that hospital?
I don't know about previous years at that hospital. I would imagine that potentially there were, but the problem is that you're not going to get a freedom of information request that tells you how many multiples were born at that hospital, or how many multiples were admitted to NICU in that hospital, because the twinhood aspect of them is used as a means to apply a lawful basis not to share, because it would make them identifiable.
Right. So when you said there's a greater number than average, are you going based on the national average then, or something?
Yes, I'm going on the national average,
right. Okay.
And I'm also going on the on the statistics around the conditions that potentially the twins that had that shared placentas potentially had. What we know is, what I see a lot is people talking about the baby wasn't growing properly, and this is something that I want to really just kind of put out there, is that oftentimes, you know, it is true to say that most clinicians, whether or not they are registrars or consultants or midwives or sonographers, they are very they practice defensively for a start, and they are also, you know, they've got a lot you know, a large caseload, and they've also got management breathing down their neck, so they're very limited in what they can do, and sometimes the information is not given over in a way that is entirely appreciative of the parent's ability to take on board information, right? And I'm never surprised at how much a family can understand if you just explain it correctly. So, you know, I have had, because this is where my work has taken me, I've supported lots of families who've lost babies after the fact, because one of their babies or both of their babies have passed away, or there's been an issue. When that happens, they might say, well, they said that the baby wasn't growing properly. And then I'll say, well, send me the ultrasound scans and the ultrasound report. And I can read it to a certain degree. And I also have some people within maternity that I can, you know, bounce off of. And what we see is, on an ultrasound scan, what you'll get what's called a growth curve, or you'll get like a plot. They plot the growth on a chart. So you'll have abdominal circumference, you'll have head circumference, you'll have femur length. What will happen is that they will say your baby's not growing properly, but the size and the growth of the baby doesn't change. There is no massive discordance, and it's called a discordance. But the issue is that one of the baby's blood flow is measuring low for gestational age, which is why an awful lot of people have gone, oh, they said this baby wasn't growing well enough, but actually there was only, you know, 30 grams or 100 grams between, which isn't a lot. But actually, what they're probably referring to is the flow of blood to the baby was lower than what they would expect for that gestational age. And so there's a huge amount of complexity around it, that if I take the NICU that we were in a big NICU. There were beds, there were empty cots, and there were babies being airlifted out of there to other hospitals and airlifted in from other hospitals. They can bring cots in, they can make space. And, you know, I said to them, how many twins do you get here? And, you know, like, oh, we haven't had a set of twins in like 3 months. That wasn't, we haven't had a death of twins in 3 months.
But wasn't it even in Lucy's testimony that she said that there were more that were admitted than normal?
Twins or babies?
Twins, multiples. There were more.
Wow.
She said, I'm sure she said in her testimony that there were more that were admitted than normal to her.
I love Liz. She does her background. Hang on. So hang on. No, 1 second. I just have to call off that. Identical twins share percent and non-identical twins have separate. No. Identical twins can share a placenta or not. Non-identical twins cannot share a placenta. Yeah, just to clarify. Carry on. I'll let you ask questions. I feel like I've given far too much information.
Mark, I'm ready to show my list. It was not 5 reasons, but 7 reasons. But I have a discussion on it about the middle one.
Yes, that's fantastic.
Which is the controversial one.
Yes, that's great, Richard. Yeah, please.
You have to do something, I think.
Oh no, I put it on.
It's up.
It's up, right? Okay,
yeah. I put it up there.
Okay, so yeah, I could imagine 5 reasons why babies were being transferred from, or were ending up at Countess of Chester and not being cared for in a unit with level 3 facilities, a hospital with level 3 facilities. And of course, a very important one is what is what parents want. I mean, there can be all kinds of reasons why parents might prefer to give birth or to have the babies cared for at Chester rather than in a big hospital over in Liverpool. Okay, that's one thing. Now, the next thing I mention here is triage, which means that
sorry, Richard, sorry, can I just jump in here with the parents' wishes, right? Okay, because that comes into choice. Richard and I, we have an understanding. He's a cantankerous old toff, and I'm a cantankerous working class hero, right? But we meet on that level, right? So we're there. But parents' wishes, right? Wishes and choice, right? But choice comes down to informed choice. Okay, so agency, autonomy, right, and capacity. Now, if you are scared, if you're afraid, and you're told that if you go there, it's going to be better, or that is a better hospital, or whatever it is, we need to kind of just take the parents' wishes out of it, because my belief is, if the parents understand what's going on in their pregnancy, and this is what I've seen in my work, they know what's going on with their babies in utero. It doesn't go wrong. It's when they don't know what's going on in utero. They are because they are. Do you see what I mean? Nobody would ever say, do you know what? I am going to just throw caution to the wind, and I don't care what you say. I'm going to this shit hospital down the road, and I'm going to just, you know what I mean, wing it. You see?
Yeah.
Right, carry on. Sorry. Get back.
Okay.
Yeah.
Yes, let me carry
on. As you were. Yeah.
I've got 4 more. Now, triage is like the hospitals, the big hospitals with the fantastic level 3 units don't have enough capacity, and actually choosing which babies to treat or not to treat, or which mothers to allow to give birth there, because they don't have enough capacity. Now, I'm not the one who can judge whether or not they have enough capacity. I understand that Sarah thinks they had plenty of capacity, so that would not be the thing there. But I mean, doctors do triage. Doctors are faced with all the time with more demands on them than they can possibly satisfy, and they have to some extent, especially when things are getting very hectic and very critical. They have to decide whether to pay more attention to a patient who has a chance of surviving than to a patient who has little chance of surviving. Anyway, so I just say it. It seems to me it could be a reason. Now,
I don't know if they have. I don't know for a fact. Like, I don't know anything for a fact. But what I was saying is, what it would be usual is, if a mother is admitted to a hospital, it would be usual. And maybe Julie might be able to jump in here with her experience, even though she wasn't in NICU. But if you had, say, a patient who was deteriorating, was likely to need ICU, would you give that bed to somebody that can? And if you had 2 who were involved in the same roadside accident, like, would you not move them before time, or what would be? Well, this is all.
It makes sense to get them where they needed to be as fast as you could, rather than wait, and then you've got a transport team to depend on, and the whole process just seems to be far more complicated if those mothers don't give birth in the right place, and every effort needs to be, isn't that's my issue, really.
And actually, we're here also at the question of the capacity of the level 3 units and the difficulty in arranging transport and so on. So I would like not to talk about these things now. These are issues, I think. Yeah. But I want to focus on the middle one, which is one which is a bit tricky. What about the motive of improving neonatal mortality statistics in Liverpool?
Yeah.
In particular, for instance, at Liverpool Women's Hospital, which is the centre of twin research. Now, obviously, it would be really immoral and wrong and terrible if babies which were possibly going to die anyway were being sent away from Liverpool to Countess of Chester in order to improve statistical results. But here is a story about why it might even be that protocols of research being done at that hospital, which is done. I mean, there are big teaching and university hospitals are doing research as well, and they're doing clinical trials. And one of the things in a clinical trial is you have to be rather careful choosing which patients you admit into your clinical trial. If you're comparing treatment A and treatment B in the same hospital, and you're going to...
Sorry, guys, 1 second. Shannon's been trying to get on. Can you let Shannon come on? Because she's been trying to get on to the live. Yeah, sorry, carry on.
Take me off, Mark. Can I just ask, has it been sorted, the echo?
I don't hear any echo now.
Okay, great. So I've done it. Okay, Mark, if you want to take me off or whatever. There's one thing I wanted to say. It's been 30 years since I've been on a ward, and I never worked neonatal anyway. But we would refuse to take a patient if we weren't staffed. You know, you'd get a call in the middle of the night or whenever. You know, someone's in A&E, you need to come up, and you say, well, we haven't got the staff. If you've got the bed, you know, if you have to have an X amount of staff, and then you'd phone the nursing officer, and the nursing officer either get you an agency staff, get somebody else, or put them somewhere else. So I don't understand. I mean, as I say, I don't know how it works now, but someone like Michelle Warden, I'm sure, if they were critically short of staff and they were a level 1 unit, and they would try a doctor, it doesn't matter if it's a consultant. If the consultant says, well, we'll bring the baby in, and she saw that, I'm sure she would say, we're not taking it.
It's kind of common sense, really, as well, isn't it?
All this.
I think there should be a bed manager or cot manager.
Yeah, the bed manager still has to ask permission to the person in charge of the ward. And it's not the consultant who's in charge of the ward, it's the nurses.
Yeah. Yeah,
the nurse in charge is the one who takes
but I don't think there wasn't a sister, I don't think, on that ward, was there not?
But that's what I'm saying. They got rid of Michelle Warden, all the senior people. They changed RNs with nursery nurses, which is not the same training. And this is I've seen this again and again, and all this new kind of privatized thinking. The first thing they want to do is get rid of senior staff because they're too expensive, and also they cause problems because senior staff won't take stuff. They won't take crap. So
exactly, and they know their stuff as well.
And they know their stuff. So they will stand heel to heel with the consultant over this sort of stuff. So I'm just wondering where that all is now. I mean, I don't know. Maybe they don't do it on neotelling. I don't know.
Someone is accountable for saying yes to admitting those patients.
Exactly. Whoever said, bring that baby in, we'll take care of them. That's the person that's responsible.
Yeah. I think it's come down to the obstetricians who are doing the cesareans twisting arms, and I think that's what needs to be identified. What was going on with those obstetricians that they were doing that surgery there at that time?
Yeah, but the thing is, but you're assuming that this is the thing. This is the question that I'm saying is like, you can't. I think we can't apply the same logic that exists within. I don't know, Mark, whether or not David. Whether or not you worked within. Mark, can you let Shannon on because she's been trying to come on and she has literally done all the work that I have with me.
Can I just say something about that? Sorry, you just asked me something. So Shannon needs to click on the link in order for me to add her to the stage. If you can ask her to do that, I've been putting messages out. If she could do that, and then I can add her to the.
Okay.
So she's not trying to get in at the moment, but I'm not sure what she's seeing on her screen, you know.
Okay, but just to go with that one, you know, I've seen, because the thing is that, you know, one of the reasons why I really felt drawn to Professor Gill was because he was not keen to hang his hat up to any one person or any group of people or anything really without anything that is steeped in any evidential fact. We'll come back to the research stuff because I think that's what Richard wants to talk about, and with good reason. But I think that the thing that I want to avoid is blaming anybody at the counter to Chester, because with it potentially, right, I'm not saying that they're not without any fault. What I'm saying is that when a woman is pregnant, if she's in labor, a midwife cannot refuse her, whether or not it's at the door. And I don't know how that works for obstetricians, but if a midwife is called to a birth legally, no matter where it is, if it's in a hospital, in a field, in her home, anyway, she cannot refuse that woman. And I myself have told women when they're not getting good care to turn up on the door of the best hospital in the country that can treat them for that need. So they cannot turn them away. So who exactly was the person or the people that were putting those babies and those women at risk? I don't know where that fault lies. I don't know if you can turn away
but you're talking about
women and babies.
I think it's an amalgamation of quite a few things, to be honest.
You're talking about conversations between hospitals and things like that. So there's a discussion between the hospital they're coming from and all that sort of thing. Obviously, whatever's happened, if someone's downstairs and there's nobody else, I mean, you would, yeah. I mean, as I say, I never worked as a midwife in that area, but you would always sort something out where the staff was managed or something would happen. And as I said, this is from hospital and these are elected admissions, which is a different thing because they can be diverted and whatever needs to be done, because otherwise you're doing them a disservice, aren't you? If you take them on, you know you can't care for them. If there's nothing else, you know, then common sense will prevail. You would do your best. But if you can't care for them, you would expect the managers or the powers that be to start figuring out what to do and how to do it.
Yeah, totally.
Back to Gill.
You want me to go up? Sorry,
right.
Sorry, Richard.
That's okay then. Well, okay. There's a story here. If you're doing medical research and you're doing trials and you want to compare to treatments, for instance, and you're giving some of your patients treatment A and some of your patients treatment B, then such a trial always has a protocol for admission. And one of the rules in the protocol is that the patients must not be too sick, because if they're so sick that it's not going to make any difference, if the person who's doing the trial, right, the person who's doing this, they believe B is better and they think everybody should get B, but they need to show that B is better by giving some patients A. Now, if they give a patient A or B at random and they know that that patient is going to die anyway, think of a cancer trial, or then there's no point in entering that patient into the trial. It's just a waste, right? You get extra noise. You get patients who are going to die anyway, whether they got A or B. So the rules of the protocol of a trial, which will be approved by in advance by the ethical committee of the university or hospital where it's done, it will have written down and agreed rules which will mean that we should not be taking too many too ill patients into this trial. And that could be a reason for a hospital to prefer mothers with extremely high risk pregnancies not to be treated at that hospital. It could be. It would be appalling if that was the case. And it wouldn't necessarily be the responsibility. I mean, it wouldn't be. It would be a decision made by people who are in good faith following rules, which they've written down and had approved, and so on. In clinical trials, you want to have as many patients as possible because you want to have good statistical. You want to have small error. You want to be able to show clearly that B is better than A. But on the other hand, you want the trial to finish as fast as possible, because if you really believe that B is better, you don't want to be. I mean, you're potentially harming all the people who got A, right? So it's full of ethical issues and complicated statistical issues. But it might, I'm just saying, it might be a reason why a hospital like Liverpool Women's was for some time not accepting such seriously risky mothers to give birth there.
Can I say something about that? Because I was reading. Is that all right? I was reading the letter over again that Sarah had written, that is published on your website, Richard. And the question I wanted to ask is with regard to this audit, isn't it? That the Liverpool Women's Hospital is part of the audit. COCH is not part of the audit. So there's this issue of, and please stop me if I'm treading into territory you don't want me to go into. Do you want me not to go into that, Sarah? You're muted.
No, you can. No, you can. It's in the public domain. It's nothing that isn't there for people to see. It's not. I'm not here to give, my opinion. In fact, I do my very best not to. So, okay. Well, Gill,
it's in the public arena that was going on, but there was. Are we to take from that there was some unofficial protocol going on to move mothers into COCH to make the figures look better at the tertiary unit at the Liverpool Women's Hospital? Is that the idea, what we're talking about?
So there were okay, so if I just go with the data, okay, right? So the data showed that there was half the perinatal mortality rate was halved in twins for that year, and there were only certain centres, part of the cohort, that was used in that audit. And so, but at the same time, what we saw was that there was an increase in singletons perinatal mortality. It shot back up pretty quickly to where it was before, right? So there's a big question there. We know that from, and I could be wrong, I'm always, I would happily be wrong. I prefer to be wrong because, it gets me off the hook. But what we see is that when we look at the projections and the accounts, because those are where you're going to find where funding comes in and funding goes out, what they're going to do with the funding, etc., what we can see is that Liverpool Women's was part of 100% of the national audits, whereas the COCH was part of a few fairly rudimentary audits. One was initiation of breastfeeding, and so on and so forth. So the question is not like, there is no question about that, unless I've misinterpreted that.
Yeah, I mean, the data doesn't lie, does it?
And it's in information that is held. Exactly right. It's there held, and what Richard has said is, when you're and also the trust in research. I campaign, as people know, much to their discontent, I campaign against something that's called twin studies, because I am the mother of twins and I don't like the fact that identical twins are considered a perfect epidemiological tool based on the twin model that was founded by Francis Galton, who was the the father of eugenics, you know. And so I find it quite grotesque, really, that those still occur when, you know, it's been debunked. But what I think people have is they have this blind faith in research, and that ethics committees, if it passes an ethics committee, it is going to be entirely safe, and it will cover, you know, it'll be ethical, you know. But if there's a hypothetical risk, that risk is big enough for it, for the research not to be undertaken. And it isn't just a risk to the mother, it's risk to human life. And so, you know, what I can tell you is that when you're pregnant with twins, the moment that you're pregnant, especially if you have twins that share a placenta, you're offered a selective reduction, or I was. Okay, and that is because it's potentially safer to reduce to one.
Are you really? I didn't know that.
Yep. And if you go ahead with the pregnancy, it is the ultimate white knuckle pregnancy, because you have to have continual monitoring, and there's always, you know, you get told that X, Y, and Z can happen. It would be a catastrophe. So you've got women who are pregnant, with families who, and every woman that's pregnant has an entire family around her telling her what she should do, what they would do in her place, and Then you've got the clinicians, and then you've got people with, you know, and so, you know, at any step of the way, some of these parents might have agreed to being part of some study. They might have agreed to be moved. They might have agreed to anything, but I can tell you this much. I was convinced, and I think I put this in the letter that I shared with Professor Gill, who posted it, is that I looked at this young woman, and I was 35 when I had my girls. I looked at this woman and I said, are my girls going to be okay? And she said, yes. And I said, do you promise me? And she stopped for a moment. I said, no, I need you to promise me. And she promised me. She couldn't possibly promise me, but she did. But I put all my faith in this woman to, and with these clinicians, to make sure that my children made it. And that's what every single mother in this case did.
Yeah. And they were
I can tell you, but I'm almost certain that the vast majority of these clinicians were believing, I should imagine, that they were doing the best thing, believing that clinical trials were ethical, potentially. And what we do know is that Letby herself did do some training at Liverpool Women's, and was potentially the most qualified person to be receptive and responsive to those babies at the right points. And so, you know, but she can't override those from higher up, and so, you know, go for the low-hanging fruit.
Well,
am I wrong or right, Gill? Have I said anything wrong there, Richard?
I'm sorry, I wasn't listening for a little bit.
Well, I've got a further question to ask, if that's all right, and it's related to what you said. If I can just read a little bit of it, you said the outcome of the audit, which is the audit including the Liverpool Women's Hospital, is that leads to funding and centres being given control over the care of multiples. You are concerned that potentially the protection of numbers for the benefits of funding then, i.e. in 2015, and continuing funding now, is leading to women who have high-risk multiple pregnancies not being under the care of specialist centres. So that suggests that you're telling us there that it was a deliberate decision of whomsoever at Liverpool Women's Hospital to push away mothers, which would in some way compromise them as a centre of twin care excellence. Have I got that right? Is that, and they're doing it deliberately?
potentially, but what I'll also add to that is that it's still happening today.
Yes,
then I'm gonna go back to Richard Gill, because he took some convincing.
I'm filling my glass. Hold on.
He's filling his glass.
Yeah.
So
it's getting late.
yeah. So you know, that is a potential. You know, that's the middle potential.
Yeah.
That Richard Gill has referred to, and it's a big question. You know, because it is an anomaly, you know.
Why
And
would
it's
a
that
team
anomaly.
of people, why would a team of people still defer babies off to another department, another hospital, when they know that it clearly didn't work? And why would they still continue to do it?
Financial reasons.
Well, yeah, the question you just raised there, Elizabeth, led to my kind of part B of the question.
Go.
The part B of the question is the receiving hospital, i.e. COCH in this case, are they, Sarah and everyone else and anyone else who could answer this, would they not be aware of something odd happening in that kind of unofficial protocol being put into place, where they're being sent mothers that they believe, or they should know, should be?
Yes, but what happens? But what happens when you raise the alarm?
Well, it comes down to, well, who are the individuals? Who are the individuals? Sorry.
Yeah.
May I say something here?
Yeah, of course. Sorry. Yeah.
So I think that I've been preparing a talk which I'm going to give tomorrow at University of Amsterdam, and I've been making lists of what the conditions were.
Oh, you're such a name dropper.
What? I have been preparing a talk, which I've got to give.
Yeah.
I mean, I've been asked to give a talk, and I've got to give it. And so I was making lists of all the babies in the indictment, and also all the deaths in the Thirlwell, which have come out of the Thirlwell inquiry. And you just go down that list of all the babies about which we know something. And again and again and again, you see babies with extraordinarily serious issues who probably, like maybe have a 50-50 chance of surviving a few weeks if they're born then, and probably not much chance of surviving to maturity at all. And in my opinion, Breary himself in particular must have known what was going on. He must, or he's so utterly incompetent, it's quite unimaginable. He's the guy who collects the mortality statistics of his hospital to send them to the Embrace UK, which publishes every year statistics of mortality, neonatal mortality and stillbirths and this, that and the other, early neonatal mortality, late neonatal mortality. He's the guy who's in the middle of collecting all that data. He has his names on the publications of that consortium or whatever it is. It's his job to know what babies are dying of in his hospital. He is the neonatal lead. It's his job. He must have known that they were receiving babies which were much too seriously ill for them to take care of, if he had any brains in his body at all. And if he didn't know, then he's criminally incompetent.
Yeah,
in my opinion.
I think that's very important, and thank you for your input. It seems like, so am I mistaken in assuming everyone on the panel is from the UK?
That's right, Hugh. Have you been following this matter? Do you have a sort of background in this at all?
Well, of course. For example, I used to work with nitrogen, and I used to...
that was Hugh.
Hugh. Lovely. Yeah.
It's been happening in recent streams that have been getting quite a lot of weird stuff happening, but I've got to be more careful who I add to the stream.
All I've got to say to Hugh is Assalamu alaikum, right? And let's not talk about the clergy, all right?
We're not going
Yeah.
down the religious route today.
You know what I mean?
I
Yeah.
can't handle that today. Not today.
Sorry, Julie, go ahead, please.
Can I just throw something in? I think a little bit more attention needs to be paid to what trials were actually going on at that time. I know there was a milk feeding trial on, and we also know around that time, we don't know if Countess of Chester was involved, but there was the respiratory syncytial virus vaccine that was being given to pregnant mothers that has since been discontinued in adults because of a risk of myasthenia gravis. Now, I'm not going completely off my trolley on this one, but I know that the RSV vaccine trial involved...
Yeah, but it doesn't make any difference to twins because it would act so differently. And I don't mean to cut you off, Julie, just because, like, or.
To me, it just, why were they? I'm just thinking out loud here. Why were they pulling those babies out early with cesareans at the wrong place? Do we have any way of finding out whether those babies were included in either vaccine trials, milk trials?
None of the twins. You won't find anything on the twins. But I can tell you that most twins that were born from 2015 to this very day are on a database of twins, no matter what. But you will not know. The big mystery around this is that whilst you will not get any information about the twins because of their twinhood, that the twinhood aspect of that will also prevent you getting any information in terms of whether or not they participated in a trial. But I can tell you this, right, for a fact, because I was there. One of my daughters was given breast milk when it came in, and the other was given formula because we were told that she wasn't tolerating feeds. And but that didn't continue. There was no issue with their feeding. In fact, the opposite has come to be in my twins, and that is that one of them is a bit lactose intolerant, the other one isn't. Going down the route of the whole twin studies and stuff, the idea that twins share 100% of their genes is a fallacy, and also there's a difference between gene and gene expression. But it is interesting to me that which is another one of Gill's slides, Professor Gill, or Gill, or Gilly. I would call you Prof, but Richard. No. But you know what? Like, because I refer to Prof all the time, Kipros all the time as Prof.
You can call me Dickie if you want to make me angry.
That's
what the G's do. They talk about Dick and Dickie.
Can I?
I've called you many things before, have I not, Gill? I've also given you an.
I remember them. Sorry, I forget them immediately.
Can I ask a follow-up question, Sarah, with regard to just to bring it back to the idea of these studies? If you don't wish to answer this, obviously it's up to you. But you say in the article that you wrote here that let me find it now. You said about these specialist centres, they've signed up to input data into all and any twin and multiple related databases, but including one that raises ever deeper concerns. So that stuck out to me as the one that raises ever deeper concerns. Can you tell us anything more about that at all? The particular one that bothers you?
If Shannon was here, which she isn't, and I wish she was, I don't know what's happened, but I would plead the fifth. But the thing is that what I know, Gill knows. So if he feels,
I could say it.
Yep. Okay.
I could say something. Okay. I mean, twin data is extraordinarily valuable. Everybody doing research into nature versus nurture likes to use data from twin registries. And the Liverpool Women's Hospital, the senior obstetrician there, is basically the personal owner of one of the, I suppose, the most important twin registry in the UK. And so this woman publishes a great deal, by the way. I suspect she gets her name on every article which is published which is written by somebody else who have used data from the twin registry. It's sort of big business. Data on twins is very, very, very important in research in genetics, in separating nature versus nurture. Yeah, is that okay, Sarah? Will that not get me arrested?
Yeah, that's good.
Next
It might get me. It might get me arrested. Who knows? But what I would say is that.
Well, I mean, you just point out some facts which are on the public.
Yeah, no,
records.
absolutely, no, but you have you know more about research than me, and you know more about stats than me, and so you know
I can get the blame.
No, you can't get the blame. No, listen, you and me will be together, all right? Okay.
Yeah, sure.
Can I?
You know, I'm not.
Can I?
What's that? Stick a pin in it. Stick a pin in it, Julie. Right, stick a pin in it. Right. Anybody that I have found on this journey that I've thought is a good person, I've said I want two things. One is that you keep me in the loop, and the other is that you keep my name, and I will give you the same thing in return. I wouldn't ask for anything. I haven't demanded anything. I'm not here for any reason but for things to be right. And as Liz will attest, I am not very comfortable in this position in front of the camera, right? And she's known me for many more years than I'd care to say. But that's why, for me, you saying it as a statistician, as a professor who understands stats and understands the academia side of it in that way, if you had come back to me, Professor Richard Gill, Dickie, if you had come back to me and said, do you know what, Sarah, there's nothing here. It's a whole, you are farming, you have got the wrong end of the stick. There is nothing here. I would be like, okay, fine. Because I'd get a get out of jail free card, or I would be like, I have got nothing. I've got no need to be here, because I'll only do something if there's a purpose to it. Right. So the purpose is the truth. The purpose is what is right. Right. So, yes, I am concerned about twin studies. I don't think that they should take place. You only have to Google who has the highest H index in the world and then look into the particular area of research that he does to know how lucrative twin studies are. And it is, and so every organization that is pretty much almost any that does does any kind of holds any data or any twin information, apart from probably my most favorite clinician, is aligned with twin studies from what I've seen. And unless there's a big lie out there, that's what I believe. But you can see it. You can see it. You can see the person that Gill has mentioned is on a board of a very big twin study board. This isn't conspiracy. This is, you can find it. You just have to know where to look.
Just got to look. Yeah.
No.
Can I throw in my scud here?
Yeah.
Someone told me, and I did check it out for myself, that there's a study going on about when to intervene with twin-to-twin transfusion intervention. And outcomes are being measured. And what we know from Professor Nicolaides is that as soon as you know, treatment should be given, because you risk losing the babies. Now, if there's a study going on that's actually delaying that intervention, how has that passed ethics committee approval?
Well, that's the question I have. Gill, can you answer that? I don't know, but you are right.
No, I can't answer it.
Can I may I say something about it? Because doing a bit of a fast catch up, it seemed to me counterintuitive, the idea that these centres of excellence would want to have as few mothers delivering twins coming to them as possible, but rather than pushing them away. Why would they do that? I understand the idea about the figures of deaths, but wouldn't they, in terms of attracting funding, wouldn't they want as many twins being born in their centres of excellence and demonstrating their abilities as opposed to pushing them away? I don't know what people think about that.
Well, actually, I answered that in what I wrote, which is one that they don't want to have such critically ill babies that they're not savable.
Right.
Yeah, they want to prove potentially, right? They may want to prove that conservative management leads to better outcomes. Okay. And conservative management is watch and wait. Whereas, but within that means that there is another disease that you can watch and wait, which was always before called TTTS, or a form of TTTS, which it isn't. Okay. But if you look on my page, you will see on my YouTube, you'll see that I've had many conversations, and I even, arranged for a symposium whereby it was very clearly stated that not tomorrow, today. And I have known women who've been pregnant with twins who have TTTS, whose babies have not made it the car journey to the hospital. And then if you watch the documentary of who Julie mentioned, Professor Kypros Nicolaides, who I call Prof, you will see that those babies that he treated at stage 3, there wasn't a high success rate. In fact, there was no success rate.
It's too late. It's too late by stage 3, isn't it?
It's too late. Late.
It's got to be at stage 1 or stage 1/2 then to intervene with the ablation and the so forth.
Can I pop in? Can I say something?
Yeah, please. Yeah, sorry, David. Yeah.
I want to change the route a bit, because it's something I've been mentioning the last couple of times in chats and stuff. The elephant in the room, which is the trusts, the creation of the trusts, all the shenanigans and all this fiddles and everything. It's only happened since the beginning of the trusts, created by Major Thatcher and endorsed and extended by TB. It's created a poisonous atmosphere. It's destroyed professionalism, and it's making everybody chase money. And it's a completely different environment. In the past, you were given, a hospital was given money from local authority, and the hospital would say, the clinicians would say, with this money, we can do this work. And that's it. And now you've got motivation by CEOs to overperform for the things they have to chase money. And nothing's going to change until the trusts are thrown out and it goes back to as it was. The authority of the nurses on the wall's gone. I mean, I heard that going back to the cleaning thing, it's about the cleaners now used to be the domestic and everyone was a team and all that. Yeah. I heard the other day that there was some. So the cleaners would do normal waste, and obviously the nurses would clean up clinical waste if there was clinical waste on the floor, and blood or whatever. So I heard the other day that a nurse said they're not allowed to touch that. They have to within the cleaning team, the private company that probably is owned by an MP somewhere that comes in and does the cleaning. That if there's clinical waste, they have a special team. They have to do it, and the nurses can't touch it. I mean, what insanity is that?
Yeah.
So that's why I'll leave it at that. Just saying, these things are going to carry on because people are chasing money. The whole mentality of care seems to have gone.
But again, in my letter I wrote, and my other half is sat here, he'll tell you, he can back me up, right? Is that, within an incubator, it's a very controlled environment. It's the humidity, it's HEPA filters, it is got the right temperature that is for the baby that's within it, and they are entirely responsive. It's beep 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 constantly. Parents wash their hands, continually. You have to wash your hands when you walk in the door, the first door, okay, and then you have to you scrub up. You go in, and you then will have to wash your hands every time you touch your baby, okay, and you have to and you also have to put an apron on, right? So the idea, and also I don't know many maternity wards or labour wards or NICU wards that don't have a leak somewhere, okay? So for me, the idea that there was like some kind of terrible thing going on that meant that they were all catching something it doesn't hold an awful lot of weight.
Okay,
I think the one thing.
What I was saying.
No,
that's not what I was talking
about. I'm getting there. Right.
Okay. I'm passionate about
this. No, I love it. No, so you're right. Okay, so they are like outsourcing cleaning companies, and they're called housekeeping companies, and they go in and they will clean up instead of the nurses and whatever. Doesn't mean that they're doing it less well, that they're outsourcing almost everything, okay? And it's not adequate, but it doesn't mean that it would cause more harm to those babies because of the environment around the incubator is not clean enough, right?
But not having enough staff wouldn't it?
Not having enough staff
would. Enough staff. Yeah.
Yep.
So that, the cleaning thing was just one aspect of a whole situation I was describing, which is the CEO and people chasing money and trying to cut costs by having less staff. The cleaning thing was that's one small thing. I'm talking about the whole.
But I can tell. But there were also two things that happened in 2015. I just want to, and I mentioned it as well. One was the Saving Babies bundle, okay, which came in, which meant that there were all of these audits that came to be, that meant that they started to look into. Gill's laughing. They started to look in.
I'm laughing about the trolls.
Yeah, I'm also comments. Seeing a lot of them as well. It's quite hilarious.
Oh, I'm not watching. I'm not watching.
Don't.
You just carry on.
Yeah, okay.
They're very amusing, really.
I know. I don't do social media. I can't. But so basically, two things that happened. One was the Saving Babies bundle, and the other was a central reporting system, because there were two massive cases in the UK that followed an inquiry. One was Baby P and the other one was Victoria Colombier, and they were like, oh, what we're going to do is we're going to have a central reporting system. We're going to protect children by making sure that everybody knows what's going on, where those babies are, or where those children are. So when people go to the dentist, they sign, even if they've said, I don't want my children's information shared. If they go to a dentist, they've signed something, it will be shared. If they go to school, it will be shared. Okay. So it's very hard to not be within a system. Okay. However, it just has created more work for less staff, David, which I'm with you. Right. Okay. Now, at that same time,
social workers, what they do,
they reduce. Yes.
What they do, they
bear with
staff.
Bear with me, right? Because what they brought in then was CICs. Yeah, so CICs were created in order to create advocates to do the role of social workers, right? Okay, and a whole number of things. when we were in NICU, my other half sat over there, and tell me if I am wrong. The two families that we remember the most, which is in my letter, were two families that were in NICU on social admissions.
So
A social admission is, Richard, I explained it to you. Does somebody else want to just to?
no, I understand. I understand
Yeah,
what.
oh,
I know
yes,
what
I remember.
So social admission is when there is a concern about the parents. Either they've lost a child through social services, or there is a history of domestic violence. And within a normal domestic violence situation, there is a time limit of like 6 months or 3 months, depending on, you know, if you're in the relationship where the domestic violence has taken place. But the moment that you're pregnant, okay, it's immediate, right? So let's say, for example, I go to the police, or no, hang on, I go to school, or I go somewhere, I go to the doctor, and they say to me, have you ever been in a domestic violence situation? And I say, oh, yes, I have. And they'll say, when? I say 20 years ago. Oh, they were like, oh yeah, your risk level is down here, right? Okay. If you're pregnant, right, even if the person that you're with is not the person that perpetuated the violence upon you, you are given the same number as if you are with the person that abused you. Okay. If you smoked a spliff at the Pyramid Stage in Glastonbury in 1996, right?
Yeah.
And the midwife says to you, have you ever smoked drugs? Yes, I did. At the Pyramid Stage in Glastonbury in 1990, it could be 2002, it doesn't matter. You get the same score. Are you a care leaver? Yes. So you get, it all stacks up. So then what happens is the woman gives birth and they're seen as being vulnerable. And what they do then is they send the babies to NICU who are healthy, okay, along with the parents. And that imposes upon NICU. The reason they do that is because it has higher staffing and locked doors. And they do that whilst they put in an application, or, you know, so those are the things that I think impacted everything more than anything.
So I'm making very general points about the reduction in professional staff, whether that be nurses or midwives or social workers. I worked in substance misuse. So the general pattern is they bring in other services, they reduce the qualified staff, and then when there's cock-ups, they bring in bits of audits and papers to try and fit the gaps, when the problem originally was simply reducing the qualified trained staff. That's what I found. I mean, I worked in substance misuse for a long time. There used to be tier 3, tier 2. If I'm going off the track too much, Mark, just tell me. There'd be tier 3, which was prescribing, so it's a medical team, nurses team. Tier 2, which was the kind of non-dependent stuff done by charities. So they were, commissions were created, commissioners would fund projects. They would then force the tier 2 and 3 together. And I'd be in a meeting where there was a mixture of non-qualified and qualified staff. It used to work well because you'd have meetings between tier 2 and 3, but we were always separated. But then we were forced to amalgamate. And then we'd been in a meeting and it would just go on for hours because they would pick it. The people couldn't prioritize. They couldn't prioritize the real problem, which is something you're saying. Because you've got less people with less qualifications, they have to have a bit of paper to guide everything. You've got an experienced social worker and they're running the things, then they would know smoking a joint 20 years ago wouldn't mean anything. The one-to-one person. See, I was just making the general point that because they've really
I'm with you on it. I'm with you on it. I'm with you on it. What I'm bringing to you is amplification of that, right? So if you've got less. So,
as I said, I was just making.
Yeah. But it was a really good point, which is why I jumped on it, is because it's not just about having, because if it was a case of you've got less qualified staff to care for a usual amount of babies, then that's one thing. But if you've got less qualified staff who are tasked with looking after babies whilst playing babysitter to babies that do not have any clinical need in NICU, right?
Yeah.
Do you see what I mean? Like,
but that's going back to the fact that there isn't enough people with sense to doing the initial assessment and everything else, because there's a manager now. See that because I've seen managers that don't know they just don't know anything, and they create these audits because, I mean, it's been so frustrating. But like the manager says to me, will you do this? And I say no, because it's a clinical thing and it's dangerous or whatever it is. Do you know what I mean? So a senior nurse says, I'm not doing that, it's dangerous. And they say, well, I'm the manager, you do it. I said, well, yes, but you're not a clinician and that's dangerous. I'm not doing it. What they've had to do in the Chester and places like this is they've had to remove those people so they can force through things that won't work, which would have been stopped before. And that's what I'm saying. So relating that back to the social worker thing, they're auditing common sense because there isn't the people there to assess people properly. As I said, an experienced social worker is not going to put somebody on a vulnerability list because they smoked a joint 20 years ago. I mean, they just wouldn't do it, would they?
Well, yeah, you'd hope not, but
you'd hope
not. You're describing a symptom of what happens when you pull out the middle, because the middle people, basically. Anyway, I'm sorry if I'm going on.
No, you're not, David. You're not going on. You're bang on the money. You know. As I say, when I first, I've started to introduce myself to people as a parent victim because I was a victim, and my family was a victim of this in 2015. My children did not get the diagnosis of TAPS until they were 6.5, which is a far more slow and progressive form of TTTS. And because I leaned into, this is if one twin is twin studies, right? Going off the twin study model, the Francis Galton eugenics model, I was like, well, if one has what looks like autism, the other one will. Lo and behold, no. Developmental issues exist within the donor twin in a TAP scenario. But we got the diagnosis at 6.5 years by chance, because I went back to the doctors and I said, I've got one child who is really struggling and another who's doing really well. And I've gone to doctors, psychologists, all the phrenologies, and I'm saying, I've got one that is displaying these traits. And they're like, well, they'll both have it. But I'm like, no, the other one doesn't. Maybe they just express it differently. And then I went back to them, oh, yeah, we now diagnose TAPS. They didn't when they were in the hospital, even though they could have done. And everything that I sent to their pediatrician, who was their pediatrician at birth, was what he had at his disposal at that time, which was a picture of the maternal side of my placenta, which was a picture of my twins being red and white, which was what he had, which was their blood tests and the issues that we were experiencing. Now in TAPS, there is a big increase in the likelihood of the donor twin because it's a slow and chronic form of hypoxia. She was born with, I didn't even know until she was 6.5 that she was born with severe acidosis. I didn't know. And do you know what the problem with that is that we weren't able to put in place things that would have helped her to feel less frustrated about existing in this world before. And that is why this matters to me. You're passionate about this. I'm passionate about this because this didn't have to happen to my girls, and it didn't have to happen within this situation. But because of all the things that you've mentioned and that I've mentioned, that Gill's mentioned, that and the bigger picture of the research, it happened. So who is going to take responsibility for that? I don't think that it should be one bloody person, right?
No, it's clearly an amalgamation of quite a few people.
But David, I'm with you. Please don't think I'm not with you. I'm totally with. Or have you? Do you still feel like I've misunderstood?
No, it's just you're talking about something very specific, and I was talking about a very general thing that relates to the dysfunctionality of the NHS. And they keep saying the NHS is failing, but they never connect that with the trusts and all the type of, just a general point, the shenanigans and the tricks that everyone's pulling, because you've got CEOs who are on £250,000 or whatever, trying to fiddle stats and to try and do more care than the staff are capable of doing. What they should do is get rid of CEOs, go back to direct funding from the and put the nurses and the clinical staff back in charge. And if they say, if there's like more babies than the units can handle, and they say we can't do this, then that's a political decision for the government to fund that more directly. But otherwise, you have to leave it to clinicians to say this is the amount of care we can give to people. What they're trying, I mean, it's happened to me with substance misuse. I had a caseload of 28 in the NHS, and then one of these cowboy companies took over. Then I was given 90. I couldn't. It was a joke. I couldn't do it.
Yep.
They created absolute chaos. I mean, and then it's like they're still doing it. And like,
do you know, David? Do you know what I'm going to do? Do you know what I'm going to do? I'm going to mute my mic because Liz knows about this a lot. Because
what do I know about
trust? No, because the whole trust situation within hospitals, right?
Yeah.
You know that, okay? And also trust in schools. Right?
Well, yeah,
so the whole
that's not what we're talking about.
Yeah, I
here,
don't know
though. We're trying to talk about Lucy Letby.
But David is. I just don't want to undermine or devalue David's.
No, his point is fair.
Point here
totally
is because it exists within education as well. Because when it was all austerity drive.
Yeah.
And yeah.
And in pharma, where I used to work, it's everywhere.
Yeah. Well, I've got a friend. Yeah. I've got a teacher friend who left for the same thing. She's been told what to teach, how to teach all the set stuff.
A lot of people that don't have anything to do with the system don't know anything about the system, and a lot of people believe what mainstream media, the news, is telling them what is currently playing out within the system, and everybody that works within it knows the truth. And it's a micromanaged clusterfuck, in my opinion, across majority of all of the trusts, really. And there are way too many cooks in the kitchen.
But not only that, I've had like managers who don't know what they're talking about trying to micromanage my practice. I mean,
you will do, totally because a lot of it's been sold off and privatised.
I mean, I used to be able to, like, I'd take a job, I'd walk into a clinic, I'd be in charge of the clinic. And now all of a sudden I've got someone following me around, checking whether I can do an injection. And this person, you know.
Yeah, this is where it comes back to Lucy. But this is where we come back to Lucy, and we need to ask the questions of whether the ward that she was working on was the ward being failed because of not enough members of staff or micromanagement. And we already know that the sister wasn't there; she'd gone, and it was a manager on the ward, like you say.
I saw someone. Exactly. And I saw someone. I saw in the Thurwell or in something where she was a co-signer. David, what is a co-signer? What was a co-signer in 2015? Was that the person that went to the doctor and said, "Can I get the medication? What medications do I need?"
Isn't that a nurse that prescribes?
If it's ward stuff, if it's an opiate, you have a drugs book. You get it out and you check it with another person. That's all. So you say, look, this is 5 milligrams of diamorph. They look at it. They sign. They agree. What you've taken out is the same amount left and everything else. So it means that both people are responsible for that drug. So when they blame all this stuff about Lucy Letby and making this opiate error, I mean, who hasn't made a drug error? And what she was saying is that she was actually
that used to be my job. That used to be my job, sorting out pharmacists that make horrific mistakes.
So a co-signer is just second nurse who agrees that it is what it is and it's what it's been prescribed and all the rest of it. So
exactly, and that is one of the twins, and but that was one of the twins, right? And then it goes back to the whole research thing. A and B, or A had an autopsy, but the baby of the twins and ENF didn't. Okay, that's questionable when there was an audit going on, right? So the A and B, but my point is that what we know is within in that information is that I've read it, and it's like, okay, so she co-signed this and she co-signed that while she was texting somebody. She was texting this person. It's like, well, she wasn't going to the pharmacy to pick up the drugs, and she wasn't like talking to the doctors. She was literally like going, yeah, this is good to go, no? Or she was not responsible for.
I'm not sure.
It was the insulin one. It was one of the Gill. It was one of the insulin ones.
Well, when I gave insulin, I didn't have to check it with anybody. It was only opiates. When I was working on a ward, you only had to check opiates. And when I was in the States, I didn't even have to check that with anybody. I had to do it myself, which was very scary, to be honest. So insulin, you don't check. You just, there it is, you pull it up and you go around. That's 30 years ago. I don't know what they do now.
You only have to check controlled drugs, Sarah.
Yeah, but there is in I don't know if it's Thurwell, a nurse that worked with her was getting Lucy to co-sign, and they were talking about that Lucy was getting ready to go on a night out and she was texting her friends and she co-signed on medications, and then they sent a blood withdrawal to Liverpool Women's that said, it was the one that we spoke about, Richard. It was the one that we spoke about where they found the insulin with the C-peptide.
Well, that babies F and L are the ones with the insulin.
Yeah,
and they're both twins.
Right. So, and there is, like, I've not known many twins that I've supported that haven't gone hypoglycemic, and then we go back to the cellular type things. But within the testimony, but my point is that within the testimony from the other nurse that was caring for the babies, within it all, Lucy was the co-signer. So she co-signed the medications, and then they criticized her for messaging people, being glib, whatever. She was getting a night out. She was going on a night out, sending messages. Well, right? There's not an awful lot of.
Right. If I'm getting someone to co-sign something that I've produced, I'd make sure they were looking at it properly.
Exactly.
If they're looking up at the phone and they're not looking at the drug, I would say, and this is the sort of thing that's different between amateurs and people that are well trained. You don't let this stuff go. You double check. You make sure someone's looked at it, they've comprehended it.
Okay, so who is more responsible in that situation for any medications given?
They're both equally responsible.
Yeah, they're both equally responsible.
But we don't know. She's saying she's doing this, but she may well have, because it only takes a minute. It only takes a few seconds of focus to say, that's 10 units.
Yeah.
That's today. That's the patient. It's for now. And check that on the other sheet. It only takes a few seconds of being totally focused, and a nurse like Lucy Letby would do that.
Yeah.
I've got something I'd like to ask, please, and it's in relation to. So we've got a situation where we've got 17 children on the indictment, and we've established that 10 of those children are multiples or parts of multiples, whether triplets or twins. Okay.
Yeah.
Now, when you look at the recent Thurwell document, the recent Thurwell document is talking about 18 deaths. Now, that's a whole history. We can get into whether we believe there are only 18 deaths or not, but let's just take it at face value. There are 18 deaths across 2015 and 2016. Now, those 18 deaths include 4 deaths which are post-transport i.e. sent to level 3 units. And there's going to be the 5th death is the one that happens on the labour suite. So of those 5 extra deaths, we don't know, do we, whether any number of those were multiple deaths either, do we? So
which ones were they?
Well, I've got them here ready to talk to you about. So we're talking about neonates born at Countess of Chester Hospital who died at a different hospital post-transfer 2015 to 2016. I don't know to what degree. I mean, they're not named. There's no initials for them, but we got the months for them. We've got a conclusion at post-mortem for some of them. And so what I'm saying whether some of these deaths are also to do with the issue to do with multiples or not.
Well, they didn't include the multiples, did they? Or am I reading your
So the one thing that we know is that if a baby is born within a hospital, because superviruses, right, is that we know that, and also if you have a home birth, if there's a transfer in, there is a risk of hypothermia, hypoglycemia, and getting a bug when they are transferred, because they are being transferred outside of their birth environment. Okay, so there is a baby within I think the one that triggered the investigation, which I think was G, but she wasn't a twin, but she was transferred very close towards the end of her NICU stay, and she got very, very sick. And so what they did do, and I don't know, Mark, maybe who looked into this, is that they changed how they input the data in between 2015 and 2016 from babies that were born at the hospital and died, and babies that were booked at the hospital and died. And I wonder whether or not that had something to do with it.
We have currently a disparity between the FOI from 2018 of 6 babies' deaths alleged to have happened from the 2018 FOI to the 2023 FOI. Where have all those deaths gone? They don't match up with these extra post-transport deaths, and that's an issue I personally got in terms of that. In that, how many deaths happened over those 2 years? I don't think anybody knows for sure, because there's a disparity in the information we've received across the FOIs across different periods of time.
Okay, so if you look at other trusts between then and now, which I have, and I would happily share them with you, you'll see, because they've published them online, how many, not Countess Chester, not Liverpool Women's, but others, when you ask any information about twins, they will use a lawful basis to not answer because of the twinhood aspect, because it would identify them, right? Yeah. So I don't know, maybe I'm not understanding your question. So your question was, there was 6.
Okay,
pose it to me again.
Yeah, I'll do it. So there's a 2018 FOI, which was the FOI people were working from, people like Dr. McLachlan and other people, Peter Elston, all kinds of people working for the 2018 FOI, which showed 17 deaths across 2015 to 2016. Now, that was obviously wrong, that FOI, even when we first saw it, because it didn't have a death in August and October 2015, and we know there should have been deaths shown there because they end up on the indictment as murder convictions. So there are potentially 19 deaths there. But what happens is the NHS later on do this thing called a manual count across various platforms. That's the way it's termed. And I received that information because someone did a complaint to the BBC, and the BBC told us that that's what the NHS did. I didn't get that directly from the NHS, but it resolves into, in 2023, there are only 13 deaths rather than 19. So 6 have kind of gone missing somewhere. Or one might also say, why were they put on there in the first place, including a death in August 2016 after Lucy Letby has left. So
when was the first? When was the first FOI put in and received?
The first eye, but by a gentleman called Walid Aslam in 2018. In 2018, which shows 17 deaths, but there are 2 missing. There are 2 missing, August and October 2015. We know they're missing because they end up as murder convictions. So I've always been going with the idea that there are 19 deaths, but it gets all changed in 2023, which so happens to.
Oh, okay. Yeah. I think it might be because they're twins.
Well, it could be. Yeah. Well, exactly. Yeah, it could be.
Yeah.
So that's another reason, because that's the thing I've been trying to work out. Why have they disappeared? You know,
yeah. But what happened, Mark? I have a question for you. When you put in for an FOI,
I did, yeah.
And so did Elston, right?
So did Elston, right? Yeah.
So what was this? What was the response, and what was the disparity in that?
Yes, it's very clear. It's very simple. The response to me was that what you said a minute ago. The numbers are so small. There's a risk of identifying individuals. But the response to Peter Elston was it would cost too much money to look into this. And that was a disparity between the responses. And that's where we are now, where Peter Elston said he's going to consider what he's going to do next. I'm not sure what he's going to do next, but that's the disparity between the responses we had.
Okay, but
Mark, can I present
yeah,
a picture?
Sorry, yes.
Yeah,
how do we do that?
I've got a list of the 18 deaths from Thirlwell.
Yeah, that would be great. I've got that up on my thing, but you can present it there. How do
I present it? I think I put it on the table to be presented.
Oh, yeah. Sorry, I beg your pardon. Yeah.
Yeah. Well, oh my God! It's. Sorry, I have to turn it around.
We can. Yeah. Shall I remove it and then we?
Yeah. Let me try again. I think.
Yeah, and then we can sort that out.
And then
this is great. I think. I'm getting hammered in the chat here, but never mind.
I can't say it. I won't look. Liz would, and you know, just whilst you're looking for that, like, can I just say, like Liz, I've known her like from the dawn of man, right? And she like, I've had people, I've said to people, like, I'm not looking for 15 minutes of fame. I won't do anything unless there's a purpose. And Liz, just please, just give your 2 penneth in your opinion of me as somebody who has been on the stage and you know,
my
in the media. In terms of, am I here because I want 15 minutes of fame?
No, I think you're here because you're a twin mum. You went through hell and back being a twin mum, and being a doula as well. And you are a staunch advocate for human rights. And there's a lot of, in my opinion, looking at this case just briefly, I don't know too much about it, but I think that there's a lot of human rights for the babies that have just been completely ignored.
And the families.
And the families. And I think that you're more interested in the human rights aspect and the equality of everything rather than yourself. I think you're very knowledgeable. And I think that you have a lot of knowledge to share, hence your letter.
But I remember saying to you, like, you know, they're like, I said, Liz, you know, I'm a backstage person. I'm not, you know, and you were like, yeah, Sarah, I said, I didn't know why you were doing the course that we were.
Yeah, I have no idea why. So, for those that don't know, we were on an acting A-level course, and I don't know why. If you say that you didn't want to be on the stage, and I don't understand why you were on our course, to be honest, because it was all about the stage, and we worked together on stage. So I don't understand why you even did it. Was it a confidence thing?
I don't know, but I remember you said to me, you said to me, even back then, you said,
Yeah.
even back then, you said that you wouldn't do this, you wouldn't do that. And I didn't understand why you were on the course.
It's bizarre as well that we both ended up, we went through that, and then we both ended up sort of in the healthcare system, and we both ended up doing jobs. Like I went along to do pharma and you did birthing, and then I obviously did lots of stuff to do with endometriosis and gynecology and stuff like that. So it was quite interesting that we both did that as well.
Yeah, but I think the thing was is that like I like the art, and I like I don't want to just stand up there and another story, and I have to go to bed soon because I'm shattered, which is why I'm being so like I'm being so like like sentimental, and that's not my strong suit. But like I remember I said to Richard, Richard, if someone was to talk to me, will you be with me when I do it? And he said, I'd be honoured. And it reminded me of educating Rita when she says, when Rita says to the professor, I just wanted to tell somebody who would understand. And he says, I'm honoured you told me. And I was like, and I said that to you, didn't I, Richard? Like,
Yeah, that's very sweet. Yep.
Can I ask something? Sorry,
can I also talk about the 18 deaths?
Yeah, please.
Can everybody see the 18 deaths? Somebody says that.
Yeah, it's small, but we've got the gist of it.
Yeah, it's very small. I mean, it needs to be shown in two bits. But the thing is, there are 1, 2, 3, 4, 5, 6, 7, 8 babies from the indictment. Right, baby A, baby C, baby D, baby E. There are 10 babies not from the indictment. They're listed in that column with yellow and white. The yellow ones are babies who are not talked about in the trial. Now, and the next column says whether the babies were born on the unit. Sorry, whether they died on the unit or off the unit. A number of the deaths which Lucy Letby is supposed to have been caused were babies who actually died elsewhere. I think baby K was one. Baby K died off the unit, right? She's supposed to have caused that death by things she did when it was on unit. That's the famous case with Jayaram lying about whether he was there or not, and Lucy was there or not, and so on and so forth. A very crucial case for the trial because it was where Jayaram believed that he had virtually seen Lucy Letby trying to kill a baby, right? Which also means he didn't see that, and he also said he didn't hear the alarms go off, but they did go off, and according to somebody else, and he apparently he actually sent a message to the the nurses. Lucy sent a message to the consultants to come quickly. And he said that didn't happen. So it's a very crucial case.
Is there evidence of that message?
Yeah. That's Thurwell has found.
So he's standing there looking at the evidence of a message and then denies it.
Well, whatever. I mean, Thurwell has published messages which were sent which contradict his evidence. Jayaram is a liar and a fantasist, but he was kind of the sidekick for Breary, I would say, because Breary was the guy who was convinced in June 2015, after there'd been these deaths. Here, this one, June 2015, 8th of June, 14th of June, and 22nd of June. That's 3 deaths in 2 weeks, and there was also a collapse in between. So there were like 4 serious events, and that's when Breary heard junior doctors talking about nurse death, and from that moment on, Breary suspected Lucy and started compiling his drawer of doom. These 3 weeks in June 2015. By the way, as I saw today on new stuff, which I saw, the coroner's office saw that too, and they thought, bloody hell, 3 deaths in 2 weeks, and it should be 3 per year, you know?
It should, yeah, and 3 per year. But also, Gill, can I just bring you in on this,
Richard,
right?
Please.
Okay.
Don't
Sorry,
call
Richard.
me Gill, please. Richard, thank you. Yeah.
Okay. Ricky.
Yeah, that's also good. Yeah, my wife calls me Ricky quite a lot.
Ricky.
I like that.
So,
as in Ricky Raccoon, yes.
So, right, okay, so we've got A and baby A, right? So baby A's mother had a huge amount of antenatal care via various doctors, right? Okay.
Right.
And then she gave birth and there was a post-mortem, right? Okay. So it would be usual that in a situation like that, there would be no need for a post-mortem. Okay. Because you have all the information you need, unless potentially something else, right?
There was a post-mortem and an inquest, but the course of death was unascertained.
Okay, right. Yeah, absolutely right. But there was a post-mortem. That's not standard practice. Even if somebody is on palliative care, which means that they have a long-term health condition. I think Liz might be able to expand on this. They don't get sent for post-mortem if they pass away in the community, if they have a medical condition, right? So then we have E&F. Okay. Now E&F, baby E passed away.
Right.
During
F is not here because F was the insulin baby who survived.
Exactly right. But E passed away during an audit. An audit that required to understand why the losses happened.
Yeah. It was 29 weeks.
But there was no post-mortem. Oh no, there was a there was no post-mortem.
These are A and B on baby E are 2 causes of death written down in the post-mortem. Necrotizing enterocolitis.
No, you said no post-mortem.
No. We're talking about baby E, aren't we?
E. It says no post, but it says no post.
Well,
baby
I mean,
E.
the letters are very small. Baby letter E. That's died on the unit, 4th of August 2015 at 1:40 a.m. At gestation of 29 weeks, and it had a post-mortem, and 2 causes were written down: necrotizing enterocolitis and prematurity. Oh, sorry, and it also says no post-mortem, so I don't understand it. But that's what Thurber wrote down. So maybe A and B are written on the death certificate.
But okay, so A had a post. Right. Okay. So right. So if you have somebody who is having an awful lot of medical care across many disciplinaries, you would not need a post-mortem because the doctors would give all the information that they have about it, the medications that they're on, and therefore you don't require a post-mortem, right? Because you know pretty much what caused the death of the baby, but there is a post-mortem in A. Now, there are 2 reasons, and I said this to you, didn't I? There are 2 reasons why there would be a post-mortem. One was because there was something that was dodgy going on. The other would be because of a study.
Yeah.
Okay. Yeah. Right. Now, do you see where I'm going?
No,
Gill?
not yet.
Right. So, but you have to, right. Postmortems can help with a study. Right.
Yes. Yes.
Now, okay. So, E and F were twins.
Yes.
Baby E, there was no post-mortem, but there was in A. But
in baby A, yes.
Who was a twin. Okay, baby E was a twin that shared a placenta, and that was within an audit. The audit was the purpose of finding out what caused the loss of these twins.
Yeah.
Therefore, a post-mortem would be reasonable, more reasonable in E and F or E as a more acute or high risk baby pregnancy, pass between trusts to see what went wrong. That's what the audit does. The audit looks for failings.
Yes.
Okay, there's no audit. Now, necrotizing enterocolitis is a very common condition that babies, that premature babies get. It's a gut problem, right?
Yes. It's
However,
a bacteria, isn't it?
Yes.
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 I
Very,
mean,
very common.
This is all the bacterial infections which the babies were getting with the
Right?
stick dripping off the walls and so on.
Yes.
Yes.
But even without it, it's a very common, like I've seen it many, many times. So my point is, right, is that A had a post-mortem and inquest, right? Now, why did A have an inquest when there were so many doctors from even, was it Guy's or Great Ormond Street?
Yeah.
That was ready to take the baby in the hospital in London. So there were all of these clinicians around this mother preparing for the birth of these babies.
Yes.
Okay. And there was no need potentially for for a post-mortem or inquest because we had all of the information, right?
Yeah.
Because we had antiphospholipid syndrome. Okay.
Right.
And then we have baby E that was a twin that shared a placenta that was having a disease that they were trying to use the audit to understand about. They moved that baby. Okay. No inquest.
Yeah. I don't know.
No post-mortem. No post-mortem. So the lack of post-mortem in baby E raises red flags with me.
Okay.
Does it make sense, or am I?
Yeah, I'm beginning to get the point. It doesn't make sense that baby E did not have a post-mortem.
No, not when it was part of. When the mother was admitted and cared for by people that were participating in the audit.
Yes, but on the other hand, we do have very reasonable causes of death of that baby written there, which presumably are written down on its death certificate. Where did Thirlwall get the causes of death of baby E, even though it had no post-mortem?
Yeah, where?
Where? Well, I don't know. I'm asking
I
you.
do.
Well, I'm asking anybody. So it had no post-mortem, but Lady Thirlwall was able to write down the two sort of official causes of death it had, because of course they have been replaced by the cause of death, air embolism, injection of air into bloodstream, and trauma to the gastrointestinal tracts causing internal bleeding, which were diagnosed by Guy Evans, and now the legal cause of death because they're in the conviction of Lucy Letby.
Yeah, the thing I just put up on the screen there was related to baby E and the panel's finding of the cause of death there. That's the panel. That's the panel's finding there.
No, I'm not criticizing you, Gill.
No.
Richard. I'm
know,
questioning.
You're pointing out a questioning, and I'm saying I don't know where Thurwell got this A and B from.
No, I'm
little
questioning.
A and little B. Little A and little B.
Yes,
Thurwell
exactly. Yeah.
Thinks that she admits there was no post-mortem, but she does fill in the cause of death, which the baby officially had till the trial determined that there was another cause of death, which was air embolism. Right?
Right.
Yeah, well, for me, it's a mystery too. I don't know where Thurwell got that information from, but I would presume that on a death certificate, there is a cause of death or several causes of death, even if it's not a post-mortem. So presumably the causes of death, which are listed here under the column conclusion at post-mortem, are not determined at post-mortem because there wasn't one, but they are still written on the on the death certificate, because as indeed Sarah was just explaining, there doesn't have to be a post-mortem in various cases.
Yeah.
But there still has to be a death certificate. And on a death certificate, there has to be a cause of death.
Yes.
So, okay. So the doctors at the hospital wrote down a little a and little b here under the conclusion at post-mortem column for baby E. Yeah, it's all terribly confusing.
Can I ask Sarah something? I'd like to ask Sarah something if you're there, Sarah.
Sarah has disappeared, I think.
Sarah disappeared.
Maybe just for the moment.
Can you send the link? Oh, she wants. Sarah needs the link back. I need to get the link back to Sarah so she can rejoin. So I'm just going to do that right now. I'm going to do the invite guest, copy, do this stuff. I'm just.
Can I say a few things about the 18?
Oh, please, Richard. Yeah.
Yeah,
please.
Just a few things. So
Thank
these are the 18 deaths listed by Thurwell and taken from one of the Thurwell inquiry documents with spreadsheets, and they are the 18 deaths in the period from January 2015 through to June 2016. So that's the period of the indictment, the period where Lucy was allegedly killing babies, and it includes deaths which happened on the unit and deaths which happened off the unit. And there are several babies who died after transfer to other hospitals, like the seventh, whose time of death said by Thurwell was irrelevant, which had multi-organ failure and no post-mortem. The thing is, you can see here a whole number of babies who died on the unit or off the unit, but who were born on the unit and who had extremely serious conditions. So a large number of these deaths are just simply not surprising at all. In particular, the ones which are not in the trial. There are how many? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 deaths which didn't enter into the trial. That's nearly two-thirds of the 18, right? Now, one of them, to be honest, is a baby who died in the labor ward. So it didn't die in the neonatal unit, and it didn't die off the unit either. It died before it had a chance to go to the unit. That's baby number 12 here. And it had congenital abnormalities, and this death was expected, and there was no post-mortem. The thing is, this just shows loud and clear there were huge numbers of babies being admitted, with mothers giving birth at the Countess of Chester with conditions which led to their babies dying, which was totally inevitable. And my point is, somebody like Breary, who was kind of in charge of this, must have fucking well known, if you pardon the expression.
Yeah, exactly.
I mean, he should have fucking well known, and if he didn't fucking well known, then he's fucking incompetent.
So, okay, like, so maybe I can give you some insight, right? So if you have congenital abnormalities, if they have taken breaths, okay, then they would get a birth certificate if they've been born with a pulse, and they'll get a birth certificate. So for me,
like number 18 here.
Yes.
Sorry, number 12. Number 12.
Yes. So I would consider that that baby may well have been a late termination because of the congenital abnormalities. Because you should know whether or not there are. But what gestation was it? 20. There was a very early one that I saw.
Maybe the number 12 in this list. Thirlwell found the gestational period irrelevant. That's what Lady Thirlwell said. You know.
Oh wow.
Has written. She isn't interested in this baby, of course, because it died on the third labour ward. But it was a death. It was a neonatal death, so it's on her list. So she's very complete and meticulous. Baby 12 is there because it's one of the deaths, and it had congenital abnormalities, and the death was expected.
Expected.
So that's what it
says. No post-mortem. Right.
No, no post-mortem. Of course not. I mean, this is sort of totally irrelevant, except that it shows that mothers were giving birth to babies whose deaths were expected. It shows that the Countess of Chester was admitting mothers to give birth who were in a terrible state, whose pregnancy was in a terrible state, where death was expected, and it happened. And this shows that Breary and Gyram lied when they said we don't expect more than 2 or 3 deaths a year to the police.
Okay. Right. So, going back to 12.
They didn't lie. It was a half truth, because in former years they didn't. In former years they didn't have more than 2 or 3, and in later years they didn't have 2 or 3. But in 2015 and the first half of 2016, they had 18. That's 1 a month. That's not 2 or 3 a year, and they knew.
But this baby, but this baby was born on labour ward, right? So, and it was expected. Okay, so
and it was expected to die.
It was but expected to die might not need. They might not have midwives. I've known babies that have been told that they've got.
But that's not my point. My point, the only point I want to make here from this table, is that Breary must have known that they were should have been expected to have about 1 death a month instead of the 2 or 3 a year, which is what he and Gyram told to the police.
Yeah, so I think that baby was a late term termination.
Yes, I mean, sure. I'm sorry, I'm not interested in that baby. That baby is just, for me. Sorry, I'm a statistician. It's a statistic.
No. Sorry. I think you're misunderstanding me. I think that the fact that it was born on labour ward, and that there was an expected death, means that it could be entirely eliminated, right?
Yeah.
That baby would not need to be born on. It could be born anywhere.
Yeah.
Because right. Right.
True.
So it doesn't matter. It's not that it doesn't matter, because no,
Yes.
Richard, you're not hearing what I'm saying, right?
Of course it does matter. I do hear you.
No,
I agree
okay,
with you and
no,
I disagree with you at the same time.
okay. It matters monumentally to the family, right? Okay, and that's when I
Of
said at the
course.
beginning of this that, like, I might say things that
I
are really
know
like
that too.
really ridiculous and like harsh, or make mistakes, be clumsy with my
course it
words, right?
matters.
But it matters to the family, but it doesn't matter to this case, because it matters in
It
order
does matter
to,
to the legal case against Lucy Letby,
yes, exactly,
because
right,
it adds evidence that Brady and Jairam lied to the police.
100%, because but that she was not responsible. That's what it, or that they lied, because that baby was
Well,
not
they told
expected to
half
make
truth.
it. Yeah. And that baby was not born on the unit. That baby was expected to not survive. And this baby being born on a labour ward means that potentially that mother was induced at a late gestation, 20 to 24 weeks, okay? And she gave birth to a baby that was not like to make it. But those baby, if they're born breathing, if they can breathe on their own, even if it's for 20 minutes, they get a birth certificate, right?
Yeah.
That's what I'm saying. Sorry, I think we've been talking at cross purposes here, but no, that baby was not, should not be in the Lucy Letby subset, but this baby is here. Why is my question?
I put it there, and Thurwell put it there, and it shows something about the kind of mothers' pregnancies which were being cared for at the Countess of Chester. In my opinion.
But you...
Okay, I get your point. Yeah, so maybe I should just erase it. But
no, not that you should erase it. It should be erased. It should be erased from Thurwell, because Lucy, right? Okay, Lucy did not cause the death, or potentially, right? Okay, allegedly or whatever, could not have caused the death of that baby, right?
No, of course not. Of course not.
Right.
Yes, I agree. We all agree on that. But I mean, it just shows. Well, it also tells you something about Thurwell, who is a lawyer, and this is a sort of administrative process which went on in Thurwell, and this is the list. I agree. The 17 other babies are the important ones because they are the ones who were on the neonatal unit.
So because I can't talk specifically about my clients, right? But just giving you an example, right? If there are certain, you can determine at 12 weeks what chromosomal abnormality a baby has, okay? But we don't do that in the UK. We leave women to wait to 20 weeks, and then we will tell them that they might have that can't be seen at 12 weeks, right?
Yeah.
And that would be something like Edwards-Plateau, or some congenital abnormality that can only be seen visibly on ultrasound, right? If that woman is told at 20 weeks that that baby is not likely to make it, she's given a choice. Do you want to go on with the pregnancy and take a punt? Or do you want to give birth now? How would you like to give birth? Right? Now, within that situation, that mother might not even have midwives at her birth. She might just have nurses that are delivering induction medication to her. Now, that induction medication is not the same induction medication that somebody has when they are giving birth to a baby that is likely to survive. And they will also counteract the pain of the induction with like strong pain relief. Okay,
No.
so that baby, okay, unlikely to survive, would not necessarily need to be born on a level 3 unit, because there's no benefit for that unless the mother says, I want to give my child the best hope in survival. Now that's the difference, and that's where the wishes comes in, right? So if the mother says,
good.
give it, you get it.
I
Oh,
get
you're
it.
so angry with me for a moment.
I wasn't angry with you. I was annoyed, obviously. But yes, you're absolutely. I get it entirely. Yes. I agree. Absolutely. The 17 was a bit of a. Sorry, that particular baby, number 12, was it? Was a bit of a diversion. It didn't.
No, it's not. It's not a diversion. It's not a diversion because Thurwell included it, right? Now, Thurwell included it for a reason. That's why you know about her or that baby.
Yeah.
If it wasn't included, you wouldn't, right?
True,
However,
it's information. Yeah.
Exactly. So the point is that a woman can give birth wherever she wants in the UK, anywhere. She can have there are certain medications. Anywhere, right?
Yeah.
So the baby that was born on the labour ward is possibly a baby that was not given palliative care, was not given pain relief, and I've told you about pain relief, and I've sent you a case study as well where you've seen where pain relief was not given. And that baby suffered, right? And it doesn't. There is no. It has no chance to thrive. But it will still be born on labour ward, but it won't have obstetricians. It won't have, unless there's an issue with the mother, it won't have midwives. It will have nurses that are literally monitoring and, making sure that the mother has pain relief, but also that the mother gives birth quickly. But there are many babies that are born like that, probably more than twins.
Yeah.
Sorry, Richard.
No, it's a good discussion.
Okay, can I? May I ask something, or sort of add something here? And Mervin's joined us as well. Sarah's gone off. I don't know if Sarah can still hear us.
He switched the sound off.
He muted himself.
No, I'm just smoking. No one knows I smoke.
I don't mind if you smoke on the street. No. What I'm really curious about, Sarah, and again, as always, please you don't need to answer if you don't want to, for your own reasons and your own things that matter to you. I understand all that. I want to be sensitive to all that, but you've presented your views on this to a number of people, to a number of journalists, to a number of people looking at this matter. It's a huge issue. This is with massive ramifications, and they've pushed you away. And why do you think they are doing that? Why do you think they're doing that? In terms of some of these journalists, because that's something that you actually raise in the letter that you put on Richard's website there.
I think because if you look at someone like Richard and Kipros, who I have a huge amount of respect for too, they have an awful lot of specific and education and experience and knowledge in their field. And so, and I recognize that too, right? So if I was to go to a statistician, I would go to Richard Gill. If I were to be pregnant again with twins, I would go to Professor Kypros Nicolaides. And then there are people that are on the outside that aren't part of the normal kind of structure, that have dedicated their lives, that might get, you know, totally, as I say, pied off, right? Because I don't have any letters after my name that is relevant or whatever. And I think that it's a cross between that, and I think that it might also be because potentially, if people listen to me, it might make a difference. Now, the bigger question is that why aren't they listening to Richard Gill, right? You know,
well,
why aren't
things which nobody understands?
Yeah, well, you know,
and I mumble and so on and so forth. Yeah,
but so do I. But so do I. So why aren't they? I can't answer that. I know what people have said to me, and that is that I take up a lot of time. Well, I can't make this easy for you fools, you know, like Richard. But Richard,
I know you took a lot of my time.
Well, the thing
Richard, how dare you?
I enjoyed it.
Yeah, we had a lovely chat in your garden. Yeah, it's worth it. And the thing is that, like, Richard has, like, there's two academics in anything that I've ever done that have ever shown me any respect. One is Richard Gill, and the other is
Nicolaides.
Yeah,
Prof. Yeah,
the only two people, and you know, and so
something. Are the journalists? Are they trying to? Are just disrespecting what you're coming up with, and or are they hiding something? Are they being told not to go down this route in some way?
Conspiracy.
Gosh,
it is a conspiracy.
I don't.
Yeah, it is. Yeah.
I mean, look,
Is the whole twin? Is the twins aspect big enough to be? Is there enough reason to hide it? Is there enough reason to hide this aspect in relation to Lucy Letby case?
I think it's just too complicated and too difficult.
Too difficult.
It's very complex. It's very complex.
It's
a little bit.
It's another story, isn't it? It's another story on top of what's happening.
It's basically another story.
Yeah, I agree with Richard Gill. I think that it is very, very complex. I think it's very niche. I think even within clinical circles, it's very, very niche. It's a very small, you know, circle of people. And I think that I can't give up on anyone.
Well, honestly.
And I think that them. I don't know. I don't know. All I know is what I've experienced, what I've seen, what I've heard. And there is no malice that lives here. There's no, I'm not vindictive. I'm not a hateful person. And
no, of course not. No.
You know, I think that, you know, and I'll talk to any of them if they come to me, the same as, you know, Richard Gill has.
I think part of the issue here is an issue which was raised recently in Peter Elston with his video discussion with a nurse whose name I forget. I'm sorry.
Michelle Warden.
Michelle Warden, who was emphasizing that the medical notes of those babies are not the only thing you should be looking at. should be looking also at the medical notes of the antenatal care of the mothers.
Yes, indeed.
And that it seems as though that like the experts at the trial did not have that, and possibly even the experts around Shu Lee have not been looking at that. I mean, they are neonatologists, right?
No.
Those experts, they study babies who've been born, but to understand the babies who've been born and their lives, short or long, or whatever they were like, you need to understand the pregnancies as well. And so there's a wealth of very, very critical medical information there, which certainly didn't make it into the trial, and possibly it's not even making it to the CCRC. And I think this is one of the big points here, and which is one of the points which is brought up by what Sarah is bringing up here, that especially, and you especially see this with twins and triplets with multiple births, the antenatal history of those pregnancies is really, really, really important. And that's part of the reason why we're just wondering why the hell were these babies born at Countess of Chester.
Yes.
Yeah. And also, and also, like, you know, like sorry, going back to the baby that we were talking about before, like, you know, why was that even included in the third one? Because that would always ever be considered a late termination, because you can have a termination up all the way in England, you know, as close to term as necessary. You know, if there's no need for care, if there's no life-saving care that would prevent the death, then it could be born anywhere. And then also, like, you know, why am I not taken seriously? You know, what judgments, you know, the way that I speak, the way that, you know, the fact that I've got no letters after my name, the fact that I'm convoluted, if I'm nothing but convoluted, you know. But, you know, the thing is that I can't make it paint by numbers.
Yeah,
Do you know what I mean? I can't simplify it. Do I think that it's something more sinister? I'm just not the type of person that subscribes to that. Maybe, I don't know.
Sure.
If they are, I don't think that it is on the scale that we are. What am I trying to say, Richard? What am I trying to say? I believe.
Well, you know,
not on the scale of Richter earthquake.
Well, can I say something? The idea that you're being blocked because of twin studies, is that a viable idea? Is that a viable idea that they're protecting twin studies in that way? Or is it just that well, in terms of Mark McDonald, for example, in terms of the legal aspect of this, are they blocking you? Do they not want to hear from you because they see what you're saying is muddying the water? I'm not saying you're muddying the water, but do they see that as that in terms of going back to antenatal care as opposed to what happened in that neonatal unit, in terms of trying to win this case for an appeal, you know?
All I'll say about that is Shannon didn't make it here tonight.
She didn't. No, she didn't, unfortunately. No.
But she has worked with me, and we have researched and we've podcasted, and we have a podcast that went out, and it's called 6 Months Investigates, because we named it on what's the difference between the truth and conspiracy. 6 months.
Yeah, I mean, I'm going to watch that video that you.
Yeah.
That you put together, yeah.
And it was about twin studies, right? So, why would I be afraid? Because for the same reason that eugenics is terrifying, I guess.
Yeah.
And there's an awful lot of protection Gill's looking confused. You know, when you're taking money out of somebody's, potentially taking power or money out of somebody's pocket, you are at risk far more than if you're doing wrong. Personally speaking, in terms of the journalists, why are they not interested? I think it's because it's not easy. It's not, it takes a lot of understanding. And when it comes to those that are leading the work that is edging towards trying to get her a retrial, that's a question I do not know the answer to.
Yeah. I mean, because in terms of the multiple births, it covers the preponderance of the babies on the indictment. It covers 10 out of 17, but it still leaves the other 7. So it's not the totality.
No, it's more. It's more than that.
Well, I think it's 10 out of the. I think it's 10 out of the 17. I think it is.
No, you have to include the co.
I have. I've included what I've included. Let me look at the thing here. I've included A, B, E, F, L, M, O, P, I, J. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yeah, that's the 10. A, B, E, F, L, M, O, P, I, J. But what we don't know.
But they're co-twins. Add the triplet, so it's 13.
Yeah, that's 13. But in terms of the indictment babies from A to Q, we've got 10 out of the 17, I think. We've got 10 out of the 17. So which is the preponderance of it. It's the greater number of it. I don't know if anyone else wants to add anything into that. But
yeah, I'm terrified enough. I can't. I don't know. Maybe
10 out of 17 is a small number. 17 is a small number, and 10 is a small number. Yes, I mean, suppose the expected number was 6, then it could easily have been 10 by chance, right? So that 10 out of the 17 are multiples is not in itself extremely. It's not statistically important, but
it should be, shouldn't it? It should be in terms of.
Well,
should it not? Should it not that you end up with a court case in which 10 out of the 17 indictment charges are based on multiple births? That has to be then a significant element of those charges, in a sense, doesn't it? And if we're thinking about an alternative,
sure, yes. I mean, yeah, there is something there with twins and triplets. I'm not saying there's not something there.
Yeah, we know there's something because they're more at risk. That's what we're discussing.
No, but that's the thing, Mervyn, is they're not.
You're not necessarily.
Yes.
But some twins and triplets are more at risk.
Sorry, are you saying that they're not more at risk if there's a twin after all that?
Not of their own, not just by being twins.
Yeah, I've seen
by being twins and triplets with all kinds of complicated extra things like TTTS. They are extraordinarily high risk.
Obviously, I'm not an expert or anything, but.
Well, actually, you don't have to be an expert.
You
don't have to be an expert. It doesn't really matter. What I'm asking now, Sarah, what are your values when it comes to your rights and other people's rights?
Are you the same guy that asked me about
Pakistanis?
The groomings? Yeah.
No.
Oh, I'd have to get rid of that guy. Same guy.
Right.
Yeah.
Going back to these multiple births.
I literally could only do 15 more minutes. I'm about to fall asleep. Go on.
Right. And being more at risk, when the hospital were doing their own internal review, they did mention that a lot of the births were multiple pregnancies, and they gave that figure of 31%. Again, they didn't mention whether it was an increase or not on previous years. Now, they mentioned this in the same meeting where they were talking about the volume of babies that they were getting in, and the weights of the babies, and the acuity levels of the babies. So the hospitals must have known something about this. And I'm just doing a simple Chat GPT search. It came up with like some sort. I think it was a Scottish survey that said twins are more at risk, even without, even taking into account weights and things, completely aside to that. But if you know more, then obviously, I'm just going by Chat GPT. But
okay. So your specific question, just to like, either break it down into more than one question, because it might help me.
Are you actually saying that being a twin itself is not necessarily a higher risk factor?
It depends on what type of twins and multiples. If they have good monitoring, if they share a placenta, they are higher risk. If they have good monitoring, they are less high risk. And if they have treatment for the conditions that the twins and multiples had in the indictment, they are even less risk. So that's where the statistics come in, because if you're taking a number of very rare twins within a hospital that should not be tasked with caring for them, and they were receiving care at a hospital that could almost certainly prevent loss and morbidity, then you have to accept that there is a potential for more questions to be asked, because being a twin in and of itself does not make a baby more likely to die neonatally if it has good care with a good physician in pregnancy, a good physician in birth, and good care after birth. If you don't have those 4 things, they are at much greater risk.
Yeah, but you can still say generally they're at higher risk, surely.
Isn't it also, hold it just a moment, because there's also birth weight and prematurity. So the risk that a twin has also depends on how early it is born and on its birth weight. And I imagine that twins are more often born prematurely and with lower birth weight. So if you want to compare twins with ordinary babies, we should be fixing birth weight and gestation.
All right, but I don't know, but I'm just saying what Chat GPT what Chat GPT was saying, that it said a Scottish cohort study found that twins delivered before.
Who did that study?
I'll bring it up in a. I'll have to check it. But this is just what it was saying. The twins delivered before 37 weeks had a 2-fold increase in perinatal death compared to those delivered 37 to 38 weeks, even after adjusting for maternal factors. This suggests that prematurity alone does not fully account for the elevated risks in twins. Additionally, neonatal unit admissions and morbidity rates are higher for twins, partly due to complications like TTTS, like you said, and placental sharing. Whether there was an increase in multiple births on previous years. Sorry, that's my writing for something else. But yeah, I'll have to bring up the study where this Scottish study was, though. I'll have to find it and look into it. But I mean, if you know, obviously you probably know more than me because I haven't looked into it. But that was my understanding. I think we've lost Sarah.
Sarah's there. Sarah there.
She's
I'm here. I'm here. I'm here. I'm just looking for some stats for you.
Yeah,
so, okay. So if you go on the ONS database, which is like flawed, it's always being pulled up for being flawed. Okay, yeah, it will tell you that 50% of twins are born prematurely. Okay, now when you look at prematurity, you have 37 weeks. Okay, right, which is before 37 weeks is preterm. Okay, but most twins will be induced at 37 weeks. That is not spontaneous preterm birth. That is birth that has been engineered, right? Okay, right. Yeah. So because what we see is that there is, and this is where I come into the growth patterns, is that twins will, in the same way that singletons do, that in the last 2 or 3 weeks of pregnancy, they will lose weight, but they will then pick it up again after, right? So if you go and look at stats in terms of singletons, you'll see that if those that are induced have a higher risk of morbidity and mortality because of induction. But those that can be left to be born with good monitoring are not in and of themselves automatically at risk. The risk is when there's no good care or when they are induced. Those are the two things that will, affect any like good outcomes in terms of birth. Because Robin Hood I've just seen this. So why isn't someone accused of murder every time a baby dies of SIDS? Because you need to go and study SIDS, because SIDS is this is another topic. But yeah. But I could tell you, but I haven't got the bandwidth right now. But
are you still there, Sarah? I don't know if we've lost you.
No, I'm here. I'm just looking for some data.
Did you follow this Sally Clark case, and was that of interest to you in terms of Sally Clark?
I don't know. Tell me.
Well, she was accused of killing her own children. It was Southall, wasn't it? Is that right? Southall?
Not Southall. That was Meadow.
It was Meadow. Sorry, it's Meadow. I always get them mixed up.
Yeah.
And she was accused of killing her own children. But we've got a similar situation here with Dewey Evans, who's kind of following in the footsteps of Southall and Meadow, and deciding that he can find murder everywhere. I just wondered if you knew of the history of that, in terms of SIDS in particular.
Well, SIDS is, so I think the guy that did that study was from Bristol University, Professor, I can't remember his name, and he worked with people at Oxford, and they went to the deaths when they happened, the very first ones, before, when it was called cot death, and they
Yes.
went in with the police and the ambulance service, and they looked around the area to see what was present, and they found that in every case there was co-sleeping with an additional pillow and without an additional extra blanket, or medication, drugs, alcohol, or smoking. So if you have got no evidence of that at all, then it should be considered to be questionable. But the data tells us that if you co-sleep responsibly, then there is no risk of SIDS. Or if you fall asleep on a couch with your baby, or if you lay your baby on their front. That was the outcome of that. So I don't know the Sally Clark case. Right. So, but those are the things that lead to SIDS. And if those things are not present, then it isn't SIDS. There is something else. And if what that is not for me to say. I don't know what but I want to look for my stats. So you carry on talking whilst I carry on searching, because every time I come out of the thing, you can't hear me.
Yeah, no worries. That's great.
But
Thanks.
There have been found genetic factors which predispose to spontaneous cot death, so with no reason whatsoever, and those were found to probably have been the cause of the fact that Sally Clark's 2 babies both died of cot death, and Meadow got her sent to jail for murder of those 2 babies, because he said, well, 1 cot death has a chance of 1 in 8,000 or something, so 2 cot deaths have a chance of 1 in 64 million, and that's impossible. So it was a murder. And he was a pediatrician, by the way, and he was a pediatrician. He was a pediatrician who was strongly supported by Dowie Evans and John Gibbs and so on, because he got struck off the list of medical doctors because he'd caused so many unjust verdicts in court cases where he'd put forward his von Munchausen by proxy hypothesis, which is that mothers are killing their babies in order to get attention or something like that. And he's not a psychologist, but he had this psychological theory. He got struck off for having caused a number of miscarriages of justice, quite a few actually. And then various pediatricians wrote letters to the newspapers saying he should come back. And a judge ruled that indeed he could come back on the list of medical doctors, because his stupidity in causing these miscarriages of justice didn't influence his ability to care for his patients.
Yeah.
But also, am I right?
Yes.
But also, like smoking, taking prescription medication, falling asleep on a couch, even having a drink, or any of those things is not murder, right? So, and there are, genetic issues that can lead to a death as well. But we also know that the genetic testing is only as good as the lab that it goes to as well, right? So I've known of babies that have clearly had some kind of congenital and chromosomal abnormality, but the tests that come back have shown that they don't.
And the people who do the tests are never going to tell you what the error rates are, because they've got a very big business doing all those tests.
Can I quickly say that I've got to go? It's late here. I'm in Georgia. It's early in the morning. I just want to say one thing. It's totally different. It's not what you're speaking about, so I'll be warned. You know the car thing, the demonstration today when nobody turned up, basically. I think there was 8 people. When I first started this off, I set up a Telegram channel, but no one came to it. Mark, have you ever thought of setting up a Telegram channel that can be a focal point where everyone can go to? Because I think there needs to be a single point. People are using Facebook. There's here, you know, and Carl and everything. If we had a single point of reference, because you know, if any, you don't have to. I mean, you know, people have been a bit reticent about going onto a channel, but you can hide your identity. You know, you don't have to say who you are at all. So,
exactly.
So if you headed it, then you could vet it. That'd be more work, and you're doing enough as it is. But if there's anyone if there's anyone who comes in that's been a problem, then they just get blocked. So it's not difficult to manage. So I'd just like to mention to everybody before I go, maybe if we have a single Telegram channel, the news about no one knew about this demonstration, as I said, because we're all split up. And if we can get everybody into one place, then I think maybe the next demonstration might end up with more people. That's all I wanted to say.
That's a great point. That's a great point, David. Absolutely, yeah, absolutely.
Good night, everybody.
Thank you, David. Good night there. God bless.
Good night.
Thank you for.
I think that the demonstration did not. I think the demonstration did not bring many participants because the person who organised it was a terrible organizer.
Well,
okay.
With Telegram, you could say, once you get a large amount there, you can say, we're doing a demonstration, who's committing themselves to go? At least you've got some idea of the number that might turn up.
Mm-hmm.
So hopefully we can do something better in the future.
Yes.
That's right, David. Thank you very much. And we've got Slingo on, who's actually one of our favourite characters here. And sorry, how are you doing, Slingo? So what have you got to say about this?
Technical problems.
Technical problems, yeah. Okay, so we were hoping to get Operation Merlin Falcon on, who's a former...
Gill.
Slingo, if you're talking, we can't hear you.
We can't hear you, Slingo. Come on. So, oh, God, Slingo's just taking the piss. So, okay, Slingo, you got to go, mate.
It's getting late in the evening.
Oh, we tried.
How do I share my screen? Or
I don't
or should
know.
I send it to you? I'll send it to you.
Yeah,
it's a button you press at the bottom.
Ask Richard Gill because he knows how to do that. You share.
I know how to do it. You can share PDF files. I mean, you can share PDF files.
Yeah.
You can't share anything. You can only share a few things. And there's a place at the bottom, just below the video, the picture of the video. There's a square which says present. And you hit that button, present. And then
I'm going to...
And then it asks... Don't worry, nothing happens then, yet. Okay. Then it asks you to choose something to present.
Okay. I'm going to go and strain the greens, right? And then I'll come back.
Is that a euphemism?
Yeah, I've been saying for a while, and then I will do it. Okay. Well, this means I have a duty of candor that nobody else understands.
Well, that was missing, the duty of candor.
I'll be back in a moment.
In terms of the consultants, great to see you, Sarah. So Sarah's fantastic, and
yes.
This is important that we're talking about this, but I'd like to say that we're talking about 10 children out of the 17 here, aren't we? Which is the preponderance of them. But we are potentially talking about more than 10 out of 17. We're talking about we don't know if there are any other multiples included in the 18 deaths that Thirlwall cites in their document. We don't know, do we?
No.
It's a known unknown, as it were. Over to you guys. Over to
where the prosecution see these patterns. They're seeing they're seeing it and go, oh, she's targeting. Both sides were trying to make sense of it.
Well, that's where Sarah is coming in with this, isn't it?
Yeah.
So Sarah's coming in with this with an idea that the preponderance of deaths are caused by twins being almost like queued up to die because they're being sent from a level 3 unit to a level 2 unit. Am I right about that? Is that the basic gist of this? That in other words, level 3 units are being pushed onto level 2 units. In this case, COCH, which makes understandable this at least part of this spike in deaths across 2015, 2016. Is that right? Am I right with this?
Yeah, well, it could be. I'm still trying to find my stats sheet. Bear with me because I am a lover of Canva and it's on Canva. Here we go. Ha ha! She hath done it.
She hath done it. That's
gather, and prepare yourself to be amazed. And I shall come back.
Gather.
Give me 2 minutes.
All right. Well, Richard, I thought the other thing about the number of deaths in the table, and you were talking about it as well, is it had been said before that there were two, not normally each year there were 2 deaths, 3 deaths, and when you see the table of deaths, and I picked this up when I saw one of the tables, not of indictments, but I was just looking at the table of deaths of the where Lucy was on shift for 8 out of the 11 in the indictments, but they also showed 6 more deaths that weren't on the indictments, and so I'm saying that I was saying the same as you. Well, hold on, if she's such a genius killer, she happens to be going on a killing spree during where there's a peak, a natural peak in deaths anyway. Like, surely if she was going to go on, if she was so evasive, surely she would wait until there's a trough and then go on a killing spree.
Okay. A really evil killer,
That's
I'm just showing how absurd it is, because they've got even if you attributed all of these, deaths to Lucy, there was still this peak. There was still a peak in deaths.
Can I say something about that? That's the classical duality of this that has been talked about since Dr. Oh God, I mixed them up. Dr. McLachlan and Professor, who's the other chap that he did that original video with?
Norman Fenton.
Norman Fenton. We were talking about this duality between being, okay, there's a serial killer at work and there's a peak of deaths and there's a spike of deaths at the same time. What's the likelihood of that duality happening? And it's crazy, you know. What it is actually is there is a spike of some sort, but I would like to question something that was said earlier, which is that this idea of 2 and 3 deaths per year prior, according to the 2018 FOI, we've got 6 and 4 deaths, not 2 and 3, not 2 deaths a year, not 3, 6 and 4 to the two years prior to 2015. That's what I want to add that to the.
Wow!
Oh, that was the FOI though. But then did they revise those numbers?
Well, the revising. So why should we believe the revising? You know. Why should
new improved?
It's the new improved, yeah.
Improved, updated.
Extra white wash, you know, yeah. Who knows? Who knows, Mervyn? Guys, everyone.
Well, maybe again, this is questions of should we count babies who die in the labour ward? Should we include babies who die after transfer?
Stillbirths.
And then there are the stillbirths. So there are all these questions which can easily make a difference of plus or minus 1 or 2. So
in the stats, you've got a 3-year period in which you've got stillbirths going from 12 to 2 to 11.
Yes.
That's a real anomaly. That's a real anomaly. That's a problem.
I agree.
That's a problem.
And Dr. McConville spoke about that the other day. Just what he was saying was, like, we're never actually going to know why that was, but it was a general, I'm not quite sure what the word is, but a snapshot of the health of the local population, if that's the right word, if you understand what I'm getting at.
I've worked it out when you're ready.
Yeah, okay. So Sarah's back in the room. And Sarah's back here.
No, carry on. When you finish talking, I'll share it. Sorry.
Well, I want. Sorry, go ahead.
It was just filler.
Well done. You are not. Yeah. Okay. Right. So, here is the presentation. Okay. So your question was around. Yeah. The question was around the stats around twins and multiples. Okay. So the only thing that I can't tell you is because I am a member of ICO, and therefore I cannot share with you the numbers of women that I've supported. But this is in the space of how do I do this? I'm trying to do it. In the space of a year that I have.
No pressure.
How do I do it? It says screen sharing is not supported on this. There we go. Right, okay. There we go. So these are the women within a 2-year period, okay, that I have.
Obviously weird characters. So sorry.
Why?
Sorry about that, guys.
They've obviously just taken the name of legitimate people.
Is that what's happening? They're taking the name?
Yeah.
Okay, yeah. Sorry about that. Sorry, anyway, go ahead. Sorry about that.
Carry on, Sarah.
Sorry, Sarah.
I'm just okay. So
I'm not going to add anybody else. I'm doing.
Okay, so as you can see, the women that I've supported have had 73% vaginal births and 26. So it's on its head. And then I'm gonna add another one. 1 second. And then I've got gestation, which should be coming up now. So 1 second. Do I click on that? Do I? Hang on. 1 moment.
Is it me, or do the numbers not add up to 100? Am I being a bit thick? Oh no, they do.
Probably don't.
They do. They do.
Okay.
It's just me. It's because I was reading it reading it upside down or sideways.
Yeah.
Okay. How do I upload the next one? Do you have to accept it, Mark?
Well, I'm not sure.
Is that it?
Is that it?
You may have to take down the previous one yourself using the 3 dots.
So
is that it? Is that the one? Or is that the one?
Hold on.
Yeah, you might be able to take them down independently.
If they're separate PDF files, you should take down the previous one and put up the next one.
Okay. Do I have to do that? Do I have to do that?
No. Sarah should do that.
Sarah should do that.
Yep, she's taken down the previous.
Okay.
And now she has got another one.
Yeah, Sarah should be able to put them up.
It's uploading it. I think it's just taking a while.
No worries, no worries. Take your time. I think this has been a really good stream.
Was that real that we saw?
Yeah.
Well, I know.
We saw some very unreal things.
I can't answer for that. But,
I wasn't really watching.
No.
Yeah. It's been entertaining.
It's been real.
Interesting.
I averted my innocent young eyes.
Bless you, my child. Bless you, my child.
Okay, hold on.
What we do for the truth, isn't it? What we do for the truth.
Yes. What you can do afterwards, Mark. I think there's something in YouTube you can do to block it out in edit.
Well, I could do, but I'm going to keep it real. I'm going to say, well, this is what we're up against.
No,
yeah.
Whilst I'm waiting for it to upload, what have I missed?
I don't think it will let you.
I haven't been. What? Well, no, I saw that.
But
I wish I had not.
Oh no, but Sarah, I can I ask you a question? And
yeah,
when we talked the other night, when we chatted the other night, you came across to me as that you're concerned about a comeback on what you're discussing, and if that is the case, but please, if you don't want to talk about this, just tell me to shut up. Why is that the case that you are concerned about what you're discussing at the moment in terms of the comeback on you?
Well, because I have like, there are some things that I don't want to say on my concerns, right?
Yeah.
But even like looking at it in terms of what I've done to this point, why have people not spoken to me? And maybe I don't think I there's not a part of me that could believe that after 5 months it's because I take up people's time.
It's odd, isn't it?
Or that I'm volatile, or that I'm unreliable, or any of those things. I'm very, very, very boundaried, and there is not one part of me that believes that I am less than another. And so when someone treats me like that, and that's why people like Richard Gill and yourself the other night, and really, really eminent people that have got my loyalty and whatever, is not because they have their name in lights or because they are up front and center. It's because they've treated me with respect, and they've also been very, very mindful and respectful of the families and the clinicians and Lucy and her family, and also anybody else that could be implicated in this. And so I don't respond to those that have got their mouth open, like going ham publicly. I respond to those that are genuine.
Yeah.
And and so when I've been treated as an underling, or I call it a downstairs attitude, and I have presented myself as I am, I don't have there's not a part of me that thinks that I should accept it.
Yes.
Even if they do. And so if I don't want to talk to you after you've treated me with such disrespect, that's not on me, that's on you. So, but that conversation isn't over forever. It's still here when you're ready to give me the respect and mutual conversation that relies upon both of us accepting that we both have expertise and thoughts, and some of us have had opportunities that have allowed for us to have letters after our names, and some of us have not.
Yes.
You know, it doesn't mean that one of us is less intellectual than the other.
No, absolutely. So we've got a situation here where we've got the Shuley and the panel have decided or have made a set of decisions in terms of the actual causes of death of all those babies. And I've lost my thought there, actually.
I think so before the expert panel came in, people were saying, oh, there were experts and they're doing it on their own pocket and, blah, 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 blah. And it's like, well, no, the best holidays I've ever had have been all expenses paid work trips, right? I go on holiday with the family, and when I get home, I have a break. And so, I don't think that the idea of somebody paying the equivalent of a bus ride for me to come and, get up front and, just speak with authority does not automatically make them entirely relevant. I don't know whether or not it's the way that I grew up or where I grew up. I've had a very strange upbringing. Like I was in and out of care. I haven't had the opportunities that others have. I'm of mixed ethnicity, and I was raised in across cultures and all of that kind of thing. But the idea to me that I am of less value does not exist, or that somebody else is of less or more value, right? So when I'm met with that, I don't have an awful lot of tolerance for it, so I'll just walk away. But as Richard Gill will tell you, I'm fucking funny and hilarious, so when I do bounce, I flounce. So I shut the door, and when I do so, I do so with humor, and they don't like it.
Okay, can I say something? In terms of the Lucy Letby case, this is dealing with 10 of the 17 cases, 10 of the 17 charges. So what of the other 7 charges then? So we're still left with those. So 10 of the 17.
10 of the 17 babies.
10 of the 17 babies, indeed, yeah.
Yes, not charges. There were
not those that you. Sorry, beg your pardon. There's 21 charges it resolves to.
Okay, but okay, right. So So if I just want to bring you back, right? Because I don't know where we went there, but anyway, when we talk about the indictment, okay.
Yeah, let's talk about the indictment.
Right. So when we look at the babies, okay, we need to look at it within the prism of perinatology. Okay, so that is pregnancy, birth, and neonatology.
Yeah.
Okay.
Yes.
Or the maternity period.
Yeah.
So, all right. So when you take a death or a morbidity that has been alleged to be at the hands of Lucy Letby, you have to just include the pregnancies. Okay?
Yeah.
Right? And then from that point, you include the babies as victims. Because for every twin or every multiple that died or suffered harm, they were part of a multiple pregnancy whereby the co-twin and the parent was harmed. So how many mothers were victims, or, well, not victims of Lucy, but how many mothers were there? Let's start with that.
Yeah. How many mothers?
In total. How many mothers? That's where you need to start.
Have we? I think we might have lost Sarah there for a minute.
No, I'm here. I just can't get the bloody.
Sorry, Sarah. No, carry on. That you're going on some fantastic stuff there. Thank you, Richard.
Can you hear me? How many mothers were there?
Yeah.
How many mothers?
You're back in the room.
Okay. How many mothers? How many mothers?
Yeah.
How many pregnancies were in the indictment?
Indeed. Yeah.
Can someone tell me?
Okay.
Less than 17.
Figures. How many mothers? How many?
Oh, I think I can answer that question. I have to have a look at
that would be on Richard's spreadsheet.
That was one of my spreadsheets.
But you got manually count.
Yeah. Which one was that one? Present.
Well, we've got A to Q, haven't we? But some of them are multiples, so we've probably got about.
It's getting late. I can count. I have to have a look.
Something of the order of. It's probably
a beautiful little spreadsheet, Lucy babies. Right. Okay. How many mothers? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Sorry, I counted wrong. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13.
Okay, 13 mothers, really? Okay, yeah.
13 mothers. Yes, because there are 3 twins. There are 2 singletons who are surviving siblings of twins, and then there's the triplet. So that you could look at it a different way. There are 1, 2, 3, 4, 5, 6. There are only 7 mothers of single babies, as far as we know.
Okay, so but there are 10 mothers of multiples.
Yes.
No, 6 mothers of multiples. 4 are twins, and 1 is a triplet.
Yeah.
That's significant, right?
I think it is. I think it's massively significant.
I think it is too. Yes.
Yeah.
And I think it is because those are very vulnerable babies.
Yep.
And all of the deaths and all of the collapses are deaths and collapses of extremely vulnerable babies. So you find the most vulnerable babies of of a grotty level 2 NICU there.
Mark, can you see my image that is on the thing down here?
Okay,
can you put it up?
Try and find it. Yeah, is that it?
There we go. Right. Okay. So, so that's the NHS. That's where I was going. So
that's a very difficult one to study.
So
by gestation.
By gestation. So you're talking about prematurity. Okay.
Yes.
Right.
Right. They're separated by.
Yep.
By gestation.
Yeah. So in a year, because I have served families who have had twin pregnancies, I would hazard a guess that I have supported more across the country monochorionic twins than potentially the County Chester. Right? So when we talk about the stats, I went there, and ONS, right? Which, you know, how many babies are born prematurely before 50% of their own fruition. If you look at my stats compared to those that are the NHS, what do you see?
This is very difficult at this stage of the evening.
So my largest 43%, is after 37 weeks.
After 30.
All right. Prior to 37 weeks is 14%.
Yeah.
And I've supported women that have had cesareans, and I've supported women that have had inductions. Most of the inductions and cesareans that happen within the NHS happen because of induction. Because at 32 weeks is when they will induce MCMA, which is very, very rare, or triplets. And then 32 to 36 is MCDA, which was mine. But my twins were born spontaneously, but they induced babies before 36 weeks in MCDA twin pregnancy births. Then you have 37 to 38 and 39 to 41. Okay. And then you have, and this is a yearly quota, and that's mine. So if babies who are twins are automatically more fragile in the absence of good care, maybe, but with good care, if twins are automatically fragile with good care, would I not have numbers reflecting that?
Sarah, I don't quite see what you're trying to say at all at the moment. And part of the problem is the numbers and the colours. It would have been useful to have used the same colours for the same categories in the two circles. Right?
Okay, so okay, right. So
I can't see what I'm supposed to be seeing because there's a lot of
All right, close your eyes, Richard. Right, and just see numbers. Okay, right. So the NHS 49%.
There's no deaths here. I don't understand what I'm looking at. There's no.
I've not had.
Births.
This is just births. Right. This is the birth stats because you said. I said statistic. You in your chat GPT that they are more vulnerable because they're twins.
Yeah.
Right.
Right.
Okay, and this is the stigma that I want to smash down. Okay. On within the NHS, and trust me, when I work, I point women towards the best doctors within the NHS that work within the NHS. Right? So they have really good monitoring. I also make sure that they go to the best neonatal hospital, if at all possible. Okay? So, okay, you have got the NHS, 32 to 36 weeks, 49% of twins and multiples are born.
Yeah.
But those are not spontaneous. Those are spontaneous and induced. Okay? Mine is 14%.
Yes.
With good monitoring. You've got 23 to 27, 2.1, the NHS. 28 to 31, 6.5. Then you've got
28 to 27. You don't have them at all. You don't have any 28
none.
To 31.
Nope. Not in twins.
The top three.
Only in one set of triplets. But these are twins. One set of triplets, right?
Yeah.
One set of triplets have got poor care. Okay. Then you've got, okay, in the blue, 37 to 38 is 40% on the NHS. Mine is 43. However, the whole thing of wishes comes into play with that, because that is based on evidence and having good care, right? The NHS, 2% are born between 39 and 41 weeks. Yeah? Mine, between 39 and 41 weeks, is 43%.
Right.
But didn't you say that's because they induced them earlier?
I said
the NHS induced them earlier.
Yeah, the NHS induced them earlier, but none of them
better care.
But I don't care for them. I just direct them towards doctors that
you
can.
make sure they get better care.
Yeah.
Yes. Yeah.
Do you see? So, you see?
It's sort of incomparable because, to begin with, the sample of mothers who come to you could be very different, look very different from the mothers who go to the NHS in general. That's one thing. I'm not saying that what you see is wrong. I'm saying this is very difficult to judge because
what is the extra sale? Because someone just explain what is extra sale.
What is extra sale? Well, all I'm saying is your mothers are not a random sample of mothers similar to mothers going to the NHS.
All of my mothers are cared for under the NHS.
Yes, I know, but not every mother chooses a doula, for instance. We could look at the demographic, the ages and the ethnicities and the incomes of the mothers who come to you, and compare them to the mothers who go to the NHS. I mean, like all the mothers, and I suspect they would be different. I suspect that you are not looking after a random sample of mothers.
No, but I have more in my numbers. I have more in 1 year MCDA twins than even a singular hospital.
Right,
and I look after these.
That already shows. Yeah, that already confirms. Supports the point I'm making. Which is just simply that it's difficult to compare the numbers on the left with the numbers on the right here because your mothers are somehow selected. There are special mothers who come to you.
No, but they're higher risk. My mothers are higher risk.
Yeah, they are higher risk. Yeah, that's one of the things. Yes. Okay. I agree. That's one of the things. They're even higher. They are higher risk and they have better results. So that's great.
Well, maybe I'm confused. What is that? What is the sale? Extra sale?
What is it? I'm not sure.
Someone. No. You're not. No. Not sale. Not sell. Sell. Someone keeps writing extra sale is the name of a participant.
No, I'm not sure what that is.
No idea.
No.
Oh, that's extra sale. I don't know.
Yeah. Well, I'll leave that. And
I don't know why that's there.
Yeah.
Mark should know why that's there. Yeah.
Yeah. Okay. So yeah.
Okay.
Well,
little technical
thing there.
Yeah.
But just.
Oh, extra sale is actually writing something now. Well, they're telling us what a doula is. Well, I thought we learned that at the beginning.
Who's Bryn? Well, why are you here, Bryn? 4 hours of your own time.
Yeah. They clearly had nothing to do.
What's this now? 2 songs. It's in
Brown
Spanish.
Dirt Cowboy. Tu son sincero hombre, Lucy's gratis pronto. I don't know what that means.
He says he hopes that she is free soon.
Free soon, yeah.
Oh, good. Okay.
You see this working class oik speak Spanish.
The oiks for the win. The oiks for the win. So, like, should we kind of bring it to a close now, guys? And it's been. Thank you, Sarah, so much, and thank you, Richard. Thank you, Mervyn. Thank you, everybody else who's kind of appeared.
This was great.
Thank you, Liz, and thank you, Julie. I don't want to miss anybody else, but do you think it's time?
Thanks, Hugh.
Thanks. Forgive me. Thanks, Hugh.
Who is Hugh? Tell Hugh.
With the pawn, the major pawn.
The troll
thing.
The troll guy.
Without that, it was.
Was that the slicing and dicing that I saw?
Weird shit. You know. But guys,
wow!
Thanks so much for this tonight.
Wow! And we are the bad guys, right?
We're the bad guys.
We are the bad guys, and someone posted
apparently
a kid having that done to them.
Oh God!
What?
Sorry, what
do you know what I mean? Like, did you not see the video that came up?
No, I didn't see anything like that. Should I delete the video then?
Yeah, you'll have to blur it out.
No, there was a video that came up on the screen, and it was a very young person being
sodomized. Something like that.
Well, he probably is not here to tell the tale, and that's why I stopped. It wasn't offensive because words don't.
I deleted them as soon as I could, but I've been having these attacks really quite a lot lately. You know, on the streams.
Yeah, the trolls are getting so angry because they're
losing. But on YouTube, how do they get through?
Oh, exactly. How do they get through?
It's so awful. Like your account might get taken down because of it. So you're gonna have to do something.
Yeah, you'll have to edit it out.
Well, what I don't want to do is to lose the stream. I don't want to lose the stream. Obviously, I don't want to lose.
There's something in the options to blur it out and things.
I'll try that.
It's quite easy to do because I've made a video before, and then you can easily add a blur because like someone's sent me an email in the middle of it, and you can like blur it out. It's easy enough to do.
Yeah,
Gill, go to bed. You need your. He's bless him. He's a good man. He is a good man.
Wonderful man. I love
yeah. Anybody that wants to contact me, they can.
Thank you.
And also, Mervyn, you're welcome to contact me as well.
No,
and oh, have I upset you?
No, that's just my sense of humour.
Mervyn's never up.
Oh my God! Oh my God! Bless you.
Don't worry. It takes a while for people to get me.
Are you convoluted as well?
He's very convoluted. But guys, it's been fantastic. Thank you so much for the stream, and God bless you all. And thank you, Sarah, and thank you, Richard, and thank you, Mervyn. Thank you, Julie, and everyone else.
Thank you,
Liz, and everyone else who. I don't want to miss anybody out. Have I missed anybody out? Have I done that?
Well, all of the
everybody.
hateful people.
Well, obviously the chat. Thank you, chat. Thank you, everybody who's listened. Thank you, all that who will listen in the future.
And everybody needs to join next week for the next installment where we talk about the clergy, right?
Oh, and we'll do it. If you want to do it, we'll do it. I'm up for it. I'm up for it. Mervin's up for it. Rich is up for it.
I'm up for anything.
Rich is up for anything. He's 3 bottles deep into a Chilean Malbec.
Three bottles.
No. I'm halfway through a bottle of Gruner Veltliner.
Oh, bless you all.
I did get you a good bottle of wine, which was hard to find in the Netherlands. May I just add?
It was good.
My booze.
It was good. I used it. It got consumed pretty fast.
Fantastic.
I thought you were going to say that you used it for cooking. I would slap you sideways.
I want to be slapped.
Oh, never.
Okay, guys, we'll leave it there. So thank you so much. God bless you. Good night.
Lots of love.
Good
Bye.
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 Where's
Bye.
the quit
Bye.
button?